Okay, I'm just going to review a few things from last week's class and go over a couple things just in case any of it wasn't clear. So, and you'll have to forgive me for my notes because I've added a lot more information, so I just want to make sure I'm getting everything straight, so I might be stopping and looking at notes here and there. Just a few review points. When you do your practice relaxation or relaxation practice, just in case I didn't mention it last time, it's just a really good time for baby also to get familiar with you relaxing, and then a good time for you guys to bond because like I said before, baby's an active participant in birth, and so when it can feel you relaxing and can feel that warm, welcoming peace, with you, then it has that sense of security also for birthing. So, go ahead.
Is the relaxing exercise something you have to do laying down, or can you do it like sitting up?
Oh, any position that's comfortable for you, as long as it's not flat on your back after 20 weeks. So yeah, just if you can relax, if you're relaxed, it doesn't have to be laying down. It can be sitting, just like we showed in the slides. So it can be sitting up or lying down, whichever. And the semi-reclined too. For the relaxation, we just don't want to do it like as a general. It's like a common thing, or do it very often. Okay, and then the sleep breathing. I just wanted to talk a little bit more about that. The goal is, just in case I didn't make this clear last time, the goal for the sleep breathing is to get that inhale to the count of 20, making that nice, deep, and controlled, and filling up your lower abdomen like that balloon, like I told you, like imagine a balloon upside down and that your lower abdomen filling up. And then exhaling at a count of 20, and long, deep, slow, controlled breaths, and when you exhale, release any tension. And the idea is to work with the surges like I showed you on the picture, how they rise and peak and fall and release. Just 1 second. There's 2 seats over here, or we can pull out some more chairs if you guys would rather not deal with the cords. Okay. Sorry, it's a little bit. Yeah, so you can come around the front if you want, or whichever. So sorry, it might be a little bit tight, but you guys are probably used to snuggling, right?
Yeah.
So here, let me see if I can shove those back there, Logan. So they're not in the corner. Sorry. Okay, there we go. No, you're fine. You're just fine. Sorry about the cords. I wish there was some way around that. Okay, so I was just reviewing some things from last week. The balloon breathing, and so anyway, the contractions when you're in active labor, and we'll talk about that more in a little bit, when they're going to last anywhere from 40 to 70 plus seconds, so they're going to be pretty long. So obviously you can't get that full inhale to the count of 20 and exhale to the count of 20 to last a full contraction or a full surge, and so the whole idea is to just have several long deep breaths throughout each surge, especially when they get longer. And once you're familiar with it, when you've been practicing those long, deep inhales and exhales, then throw that counting out the window. Just in case I didn't say that last time, it's really important. Just make sure you throw that counting out the window because it can be a distraction and you can't fully relax if you're always counting. So just want to make sure I went over that. And then we didn't talk about light touch massage, so I just want to go in to that really quick, and then I kind of talked about it briefly on one of the slides, but I was going to ask if I can have a volunteer. Actually, can I use your just because you're right here? You're what? Well, because I'm your partner. So I'm going to actually turn her chair. Oh, can I leave these? Can Laura hold them for you? So yes. So and then this is just an example. You can do it in any position. You can be lying down, you can be semi-reclined, you can use it on your arms, on your back, whatever. So do you want to straddle it? Is that okay? The chair? Sure. Okay. So you can put a pillow on the chair if this is comfortable to you. This position is pretty comfortable to a lot of people because it kind of gives that natural spread of your thighs and your hips. So you could even use this if it's comfortable to you. You could use it leaning against the birth ball too, or the yoga ball. And you can just kind of rest your head on your hands if you want to do that for us, Emily. And then the idea, again, is just to stimulate kind of the goosebump effect, or because it just releases endorphins. So You're just going to do light and some pain time. If it's too ticklish to you, you can do extra pressure. So I can just go like this. So some people.
I think you need to put.
Okay, I was just going to say, so that's why I say to practice. So because some people are like, oh, I need it deeper. But you don't want like a deep tissue massage is the idea, okay? Sometimes during labor, we'll give a deep tissue massage, but it's usually in the hip and buttocks area. But this, you just want it to be relaxing and calming. For some people, I would do this, but that's going to tickle. Oh, there we go. See? So it's not tickling her. I just had to, well, okay, it is. So anyway, that's just the whole idea. And then you go over to the shoulders, and you can go up and around, and then you can even do like the figure 8, like I was saying. So the more you practice, the more you get kind of rub out that ticklish. The more you practice, the more you get familiar with what is really comfortable and soothing to your wife. And then use that during your relaxation practice too. So, and because you can use it during birthing most of the time, not always, it's very soothing and calming during birthing for the ladies to have this done, especially if it's her husband that's doing it. And so also, having said that, don't be offended if your wife during labor, especially in active labor, if she's like stop and like shouts at you or snaps at you, because sometimes what she loved before is she's not going to love during labor. So women, you can be aware of that. Don't beat yourselves up if you kind of get a little bit grumpy and you're just trying to focus. That's normal. Birth preferences. Let's see. Actually, let me just make sure I've gotten. Okay. Fear release. We didn't talk a lot about that. We did talk about fear in the first few classes, but I just want to ask that each of you, if you will, if you want to take some time over this next week to like write down 5 things that are concerning to you, either surrounding birthing or just surrounding life in general. If it's surrounding birthing, it would be even better, and if you can come up with those things. Husbands, if you come up with stressful things too, I encourage the husbands and wives to do this together, to sit together and write down things that are worrisome, causing some fear or anxiety around birthing. Even sometimes husbands have things that they're anxious and fearful about for their wives for birthing too. So, and it could, like I said, it could be life in general stuff. So, and then make a list, and then limit that list down to 1 thing each. And then if you will listen to the this NLP script that I sent to you, or the library emotion script. I think those are the ones. Let me just make sure. Yeah, the NLP projection room release, or the library emotion release scripts. If you don't like them, it's just if you take the opportunity to allow what they're trying to do with you through those scripts, it's helpful for a lot of people. A lot of people who've had fear surrounding birthing, or just life stressors in general, have used these, and it's been helpful to them. But if you don't like it and you find one that you like better on YouTube, or you feel like you don't need it, that's fine. But I encourage you to at least give it a try if you feel like you need it, if you're having some fears or anxiety that's keep coming up. Okay, so food, really quick. So Grace asked a really good question last time that it kind of stumped me for a second, even though I knew it, but there's just so much that I was going over. She was saying that, or asking if we need protein with every bite of food. So just to make that clear, you don't need protein if you're eating vegetables that are non-starchy vegetables. If you do, that's great. It's even better for you. In fact, there's been some studies done that show that if you eat vegetables first, it actually helps your blood sugars. If you eat vegetables first, then your proteins, and then your carbs, it helps your blood sugars. So, whatever you would like. But so if you want to have a snack and it's just like some carrot sticks, celery sticks, things like that, you don't necessarily have to have a protein with the non-starchy vegetables. But if you want to, it would be even better. You're just getting more protein in. So does that help with that? I don't know if I made that clear last week or not. But again, if you're eating starchy vegetables or starchy carbs, then you want to for sure get that protein in there. No naked carbs. Let's see. Yeah.
We're looking at this page in the book.
You were what? Sorry.
I was just bringing up this page in the.
Oh, just to let everybody know that there's that.
Yeah.
Okay, yeah. So some have asked, how do we track our protein? So that one is pretty good. It might be outdated. In fact, I've been wanting to check it, but I think that it's pretty good. So there is that protein tracker in your book, and it gives you an idea of a lot of proteins in there, and how many grams in each, or protein sources and the grams in each one, in case you're wondering. So the general rule, again, like I said last time, is 80 to 100 grams. But when you're building a baby, when you're growing a baby, you've got to be closer to that 100 grams, especially if you're active, if you're on the go a lot, and if you have a really fast metabolism. You probably need a lot more than that 80 grams. You need closer to that 100, probably even more than 100 grams. And I know that's difficult. But every metabolic process in your body, including growing a baby and birthing a baby, needs protein. And not just like pea protein or plant protein. It needs the actual animal protein. So collagen can actually, if you guys ever do collagen powder or collagen drinks or anything like that, that can be added to that. You just don't want that to be the bulk of your protein. Or like I said last time, the collagen or the protein bars, protein shakes, protein drinks, things like that. You don't want that to be the bulk. Those could just be fillers if you're like in a hurry or something like that. So mostly you want to have that whole food protein. And then I have a handout really quick on healthy snacking. I told you guys about, I think I mentioned it. So if you guys don't mind just taking one and passing it around. And then you can just look at this after, because I'm not going to go over a lot of that, but it's just something that's helpful in case you're like, well, what else do I snack on? This is just helpful. Okay, let me just make sure. Got everything? Okay. To start with this, today I am going a little bit back. So in your booklets, make sure I've got it. At the beginning of class 3, I think we just kind of just skipped over that. There's this little poem type thing or affirmation for dads. So I'm wondering if, let's see, Tyler, will you read that for us? Daddy's Promise one on there. So beginning of class 3. So if you guys will just turn to that and follow along. This goes along with what I was talking about last week with dads and they're being supportive.
I promise to love you unconditionally. I promise to protect you, for your pain hurts me more than my own. I promise to guard and to guide you, materially, mentally, and morally. I promise to foster soundness and strength in your health, your head, and your heart. I promise to catch you doing things right, and to let you do things your way, no matter how messy or asymmetrical. I promise to applaud your accomplishments, whether they be anonymous for nobody's eyes or world famous for the Nobel Prize. I promise to be honest, open, and direct. I promise to be a pillar of courage and a pillow of comfort. I promise to explore the world with you, explain the world to you, and expect the world of you. I promise to be a fortress in which you can hide, a friend in whom you can confide, and a father in whose heart you'll find love, and in whose eyes you'll find pride.
Thank you. Thanks so much. I feel like if, and I say this in every class too, but it's so true that if we had fathers like that more in general throughout this world, that our world would be a better place right now. So not that it's always up to the fathers, but the huge impact that they have on our children and on your wives and families. Okay, so we talked a little bit about birth preferences, birth plans, creating birth plans, and I just want to go over really quick some things about that I didn't mention last time that are important. It is important that that you do everything that you can to achieve your birthing goals, and that whoever is helping you, your caregiver, your support person, doula, midwife, everybody who's going to be there with you at your birthing is supportive in your goals, that if things don't go the way that you wanted, it's not a time to be confrontational or upset. We talked about that a little bit, but we just had, people be either, upset at, circumstances surrounding their birthing. Everybody there is there for you and wants to help you and give you, everything that they possibly can. And also, if mothers are planning a home birth and they end up in the hospital, it's really, really important that you don't beat yourselves up. If you've done everything you can, what time allows and all your efforts that you had time to and could put into your birthing, and it didn't go the way you wanted it to, don't beat yourselves up. If you're at home, you wanted a home birth and you end up in the hospital, or even like worst case, not worst case actually, but even worse than that for a lot of people, if you planned a home birth and you ended up with a C-section, those are, I know of some women that have done everything they possibly can in their birthing and practicing before, and still end up in the hospital and sometimes end up in a C-section. And sometimes we find out why these things happen, and we're there and baby's delivered and we are like, oh my goodness, that's why there's this issue that was happening with mom and baby. And sometimes we don't. But the most important thing is, of course, that mother and baby are well and healthy and strong. And also that you allow yourself, if this does happen, or you allow yourself the time to process what happened and be gracious to yourself, and not beat yourself up and think, oh, what did I do wrong, or like that. There's of course there's always learning experiences, but just don't beat yourself up. Ask for support, ask for help, ask to talk through things if things don't go exactly how you planned. So I just want to make sure I got that in there before I didn't say that. So also, if you do end up in the hospital, we just want to say, if it's a planned home birth, that sometimes we've had couples that are just really confrontational to the hospital staff. And we just want to remind everybody that they're there to help us. They're there to give their resources and their help. And so we're so grateful for them and what they have to offer if you end up being at home. If you end up being at the hospital and planning it on at home. So work with the staff. Ask your doula or the midwife, questions. Be informed. It's so important to be informed. But having said that, I just want to hand this out too. This is the practice responses for birth preferences in case you have a birth plan, or in case you just have, even if you don't have a birth plan written down, then you have an idea of what you want. If you can just take one and pass it down. Those are just some things to kind of look off of and bounce ideas off of, what could be said in the hospital, or even, mostly it's for hospital, but if you're at home too, there's things that maybe don't go according to plan. And so it's really good to be informed and ask questions. Okay, so I am done with that, going over the reviewing, and I will continue from here. Okay, so we know that there's the optimal birthing position, and I just want to show these things not so that you can focus on them, of course, but just so that you can have an idea in case baby is presenting a different way than the optimal birth position at birthing, and you happen to hear your midwife or caregiver say, oh, your baby is doing this. So this is complete flexion right here, and the vertex position, which is optimal. This is what we're looking for. Baby's chin tucked, sorry about that, and the crown of baby's head coming through the birth path, through the cervix into the birth path. And then this is what we call moderate flexion. So baby's head isn't like this, but just a little bit more like this. It's more difficult. These are all deliverable positions, vaginally deliverable positions, but just sometimes more difficult. And then here we have poor flexion, where they're coming like almost what we call military style, so like the top of their head. And then full face presentation. So this is what it would look like if we were, being the midwife or the doula, looking straight on and seeing baby come. We'd see baby's face presenting instead of the back of the head. This is something that is quite shocking, but it's, again, I've seen babies born this way, and baby and mother did great. It's just a lot more work. So Don't want to focus on those things, just want to show them there what possibilities are. This is what we want to focus on right here, and then right here, this just shows a different angle. This is, again, if your baby, if you hear your midwife say baby's posterior, again, a deliverable position, just more back labor, more likely more back labor. In fact, I don't know of a labor where a baby was posterior and then mother didn't have a lot of back labor. So babies will also oftentimes turn themselves from posterior to anterior once it gets close to, when mother gets close to being complete in dilation, and they'll just kind of flip themselves into the right position, and you notice mother's back labor go away and baby comes anterior. So okay, again, optimal birthing position. You guys have this picture. I hope everybody hung it up so they can look at it often. These are special circumstances. Reasons to call your midwife if any of these things occur, or anything else that is just extra concerning to you that is not on here. If you notice fresh red blood, and these things could be happening before labor or even during labor, some of them, or when you're just early stages of labor and your midwife's not there. So if you notice any fresh red blood coming from your vagina or your rectum, if you have chills or fever, severe continual headache with dizziness and spotty vision, unusual pain in the abdomen, excessive or continual vomiting. All these things seem obvious, but some people do just like kind of brush things off and think, oh, I'm fine. But you need to let your midwife or caregiver know if you're noticing these things. Considerably diminished movement of baby for more than 4 hours, and there is a fetal kick count. I recommend you guys try it a couple times if you haven't already. That's in your binders, your white binders that you bring to the prenatals. And if you aren't coming here to prenatals, I will get you that fetal kick count. If you want it, just ask me if you guys want it, okay? It's just instructions on how to do it, and then you can, a little chart on monitoring it, the baby's fetal kick count. Membranes release, note so you're water breaking. I want you to note if it's a greenish color, brownish color, or if it's just like a clear, and if it has any foul smell. So even if you're not sure, you just think that maybe your membranes have released, your water has broke, always call your caregiver, your midwife, or your OB, and then just ask them, like, can you just come and check? There is a special swab that we can use to see if it's amniotic fluid. And sometimes when labor gets, a lot of times, often, women have excessive vaginal discharge, some so much that they wonder if their amniotic fluid is leaking. And a lot of times it is just vaginal discharge. So, but having said that, like, it doesn't hurt to just ask, just in case. We would rather that and find out that it's not, than just thinking, oh, it's not the amniotic fluid, and then find out later that it was. So prolonged delay in start of labor after membranes release. So if your water breaks, obviously you're going to let your caregiver, your midwife, know that your water is broke, and if it's confirmed, then normally we'll be monitoring this, and if it's been longer than 12 hours, then we're going to have to do some things to get contractions going if there's no contractions before. So we want to for sure get some things, some contractions going, so that because there is an imminent, not like immediate risk to mother and baby if your water breaks and you don't start labor all of a sudden, but the longer it goes, the higher the risk is of infection to mom and baby. So we like to have good labor going by at least like 20 hours after your water breaks. So large amounts of thick mucus or blood-stained mucus, if you notice that. Severe swelling in hands, feet, ankles, face, or neck. Sharp chest or back pains not letting up. A feeling of a need to push, Braxton Hicks or contractions coming in a pattern before 37 weeks. A pattern would be for Braxton Hicks, so everybody knows what the Braxton Hicks are, correct? That tightening that's not actual contractions. If you're before 37 weeks and you're feeling more than 10 in an hour, that's a general rule, then you need to let your midwife know, or your OB. High blood pressure after delivery. Sometimes, and this is on here because sometimes women don't realize, and they don't say anything to their midwife or their caregiver, and they do get that. There is a postpartum toxemia that does happen. It's rare, but it does happen, so we want to make sure. that you're staying in communication with your midwife or your OB. Okay, looking at the due date. So the due date, we put this on here because there's so many women who get really fixed on their due date. Like, this is when my baby's due, this is when my baby's coming. But it's actually a really wide window of gestation. It's 265 to 300 days, so 42.9 weeks, almost 43 weeks. Of course, we don't want a mother to go to that 43 weeks. Once a mother gets to the 42 weeks, or even close to that 42 weeks, we're going to be doing things to encourage labor to start, natural things. But it is an estimated date of delivery. It's a time frame to work with. Full term is considered 37 to 42 weeks. Technically, like medically, you're not considered overdue until 42 weeks. A lot of this depends on your menstrual cycle length. So women who ovulate really late tend to deliver their babies later. And some women don't know when they ovulate, so they don't know. You want to think of it as your birth month or birth time instead of due date. Avoid well-meaning family members and friends asking about labor starting. Like, it gets closer to that due date. You've told people your due date, and so they're calling you, which happens a lot. They're calling you like, "You doing anything? Are you doing anything?" It puts a lot of pressure on the mom. Any contractions yet? Did your water break? What's going on? How are you feeling? And it puts pressure on the mom, thinking that they have to be doing something. They have to be starting their labor. So I recommend just telling people, if that happens, just very kindly say, "We'll let you know. Just don't ask me. Don't ask me how I'm doing. Don't ask me if I started any contractions yet. Just I'll let you know if anything starts." It does put pressure on the mothers. So just ask for patience. Baby sets the pace. Ideally, the mother and baby are perfectly in tune from time of conception. Placenta works beautifully for the mother and the baby. Not only is it a special organ that provides nourishment and is a liver filter or anything like that, but it also works as a communication route, like hormonal communication between mother and baby through the amniotic fluid, through the placenta, through the uterus. It's really amazing. And what's going on with baby, it communicates with mother's pituitary, with mother's brain, and back to baby. With the help of the umbilical cord, it provides communication between baby and mother's brain, and mother's pituitary, of course, it's in the brain. So sends information about baby's needs and mother's body and necessary hormones to provide for it. Baby's development is complete. So once baby's development is complete, there's specific proteins that are released from the baby's lungs, and baby's lungs say, "Okay, I'm done, it's time." And this is what normally happens. This is what is supposed to happen. And there's a response in the uterus from that. And then labor signals are sent to mother's pituitary. And so your mother's pituitary, the mother's pituitary sends signals for surfactants to release in baby's lungs so that baby can breathe even better when he's born, and for them to work effectively. And so the amniotic fluid releases hormones that travel to the mother's pituitary, sending a message to the uterus to take action once that surfactant is significantly, coating the baby's lungs. So this is normally what happens. Again, don't focus on it. There's a lot of women who they'll say, "Well, my mother delivered early, my sisters delivered early, my aunts delivered early. I just know I'm going to deliver early." That doesn't always happen. Like, very rarely does that happen. There's only about 3 to 5%. Oh, it's right there. 3 to 5% of babies that are born on their given due date. So, or even close to it. So don't get hung up on that. It's way better to plan for that, 37 weeks and just be ready, but to just have that mental, that mindset that I'm going to go over. I'm most likely going to go to 41 weeks. And then if you're prepared and you come early, then that's great, earlier than you thought. Okay, these are some more signs that baby's nearly ready with your body and with baby. The lightening is when baby drops further down into the pelvis. So if you're getting measured at your prenatal appointments and they're doing the fundal height measurement, then usually it'll plateau, like stay the same, or it'll drop. So say you're measuring about 36 or 37 inches, centimeters, sorry, not inches, centimeters or 38 centimeters, and then the next prenatal appointment you're like 36 centimeters, and it drops. Usually that's an indication that baby's dropped further into the pelvis, and you may be able to breathe more easily. This is usually a sign that baby has dropped into the pelvis. Your heartburn and indigestion might improve. You might notice an increase in the pre-labor warm-ups, the Braxton Hicks or the practice contractions. Might notice that they're coming closer together and be more intense. There is in your white binders, there's a section in there, I think it's in the preparing for birth, and it says there is no false labor, or the birthing section. And I encourage all of you guys to read over that because there's not time to go into that now. But I know you guys have all heard, or I'm sure you guys have all heard that false labor. I was in false labor on and off. You know, I had false labor and I had false labor. There is actually no false labor. So what it is your body's practicing labor, and it's just like, okay, this is what we're going to do. We're having some hard contractions. They're coming consistently. You know, they're lasting like over 40 seconds, almost a minute. You know, coming every 10 minutes, and then, or even sometimes 5 minutes, and then you think, I'm going to have baby, and you go to bed, and like, I'm just going to get some rest. You go to bed, you wake up in the morning, and all the labor's stopped, and it's gone. So that is very, very, very common, and a lot of people think, oh, that was false labor. It's not false labor, it's just practice. Your body's practicing what it's supposed to be doing. So I actually have that for you, Gracie. And I didn't think of you guys, sorry. I was thinking that you guys were coming to us. So I will get this to you too, okay? So I will remember Grace and Bian to get one of those copies for you guys. Let's see. The intense nesting instinct is a very real thing for many people, where they just want to, for many women, where they just want to clean everything and they want to just get everything perfect. And it is very, very real. Like even women who are generally not like super OCD about stuff, when it comes time to like around 36 weeks, they're going to want to clean everything, have everything perfect. And that's good. That's a good thing. So we often just don't run yourselves ragged, don't wear yourselves out. So you often see also see a weight gain plateau. So your weight, you know, each prenatal appointment is gradually rising, and so usually at around 37, 38 weeks, you see that plateau and that weight gain kind of slow down too for mother. So, okay. Any questions on all this information that I am racing through like crazy? Okay. So I don't want you to focus on this, but I just like to put this here just in case, in the event that might arise that you're in the hospital and this is offered to you. Okay, so forms of artificial induction, almost all of them have an increased risk of C-section, and we want to avoid them if possible. Sometimes they're necessary measures because it's what can get baby here, and then again, we're grateful for them, but we want to avoid them if possible. So there's a cervical balloon. It's a balloon that's inserted. It's like a tube that blows up and actually opens the cervix. Very intense, very traumatic to mother and baby. And I'm not going to go over them a ton, but synthetic prostaglandin, Cytotec, it's a pill that's given and they're inserted into their rectum, and it's supposed to, at night, it's supposed to induce labor in the morning. Again, sorry, did somebody say?
Did you say it just says that it's inserted in the vagina, not the rectum?
Oh, or sometimes it's the rectum.
Oh, okay.
Sorry. Vagina. So yeah, either one. It's meant to have contractions going in the morning. So a lot of times there's a lot of bleeding with that, which we don't like to see in normal births. And there is almost always severe pain and cramping that's abnormal to normal contractions, like a lot more intense. Pitocin is very commonly used. It's a synthetic form of oxytocin. Induces the uterine contractions. It normally speeds up the pace of contractions as well as increases the intensity of each one. Some possible side effects are they're very intense and sharp. So this is like an example. This is to show transition phase, but really I put it here because it's to show an example of what normal contractions are like, and if you had Pitocin, what your contractions would be like. Most Pitocin inductions end up, or even all of these end up with an epidural. So if you're planning on not having an epidural, I've only know of like a couple people that have had Pitocin and not gotten an epidural. So artificial rupture of membranes, a lot of times in the hospital, when you get to be about 6 centimeters, they'll keep asking you, do you want your water broke? Do you want your water broke? So it'll speed up labor. It doesn't always speed up labor. In fact, it doesn't even 50% of the time speed up labor. So it's so much better to leave that cushion there for the baby. It's a shock absorber for baby. It's a shock absorber for mother. And it's just a lot more comfortable for mother and baby if that amniotic fluid is left there until it breaks on its own. And this is just a cord prolapse. This is just very rare, but one of the side effects of having amniotic fluid, your amniotic fluid broken too early. And usually it's only if babies breech or just some other rare conditions. But anyways, we don't want to. So achieving a natural start of labor, I'm going to mention these quickly, but keep in mind that most of these will not work unless your baby is ready. There are some rare cases where you can get labor going if your body or your baby's not ready. But in those cases, generally that labor is going to be a lot more drawn out, a lot more intense, and going to wear mother out even more quickly. So it's so important to just be patient, allow your body and your baby the time to start labor on its own when it needs to. And if it gets closer to that 41 plus, then we'll start talking about, measures that we can take naturally to increase, contractions and get that labor going. So these are just some ideas. Evening primrose oil, orally 5 weeks prior to estimated due date, and vaginally 3 weeks prior to estimated due date. There's an evening primrose oil protocol that we midwives have, that we encourage our ladies to do if they would like to, that we've noticed really good results from labor just kind of not going clear over, ladies not going clear overdue, and also birth not being so long. But it doesn't always, it's not a guarantee. So spicy foods have been known to start labor. Making love, the same energy to create, can be used to bring baby here. Acupressure, acupuncture, chiropractic adjustments. Sometimes those hips are just not in the right place, so baby can't drop down onto the pelvis the right way, so that it can't put the adequate pressure onto the cervix to stimulate the oxytocin and the other labor hormones and get them going. So sometimes that chiropractic adjustment will help with that. A warm, relaxing bath or time alone in nature spent visualizing, rest, remove stress. A lot of times mothers just are so stressed about wanting labor to start and getting it to start that they can't relax, and so labor doesn't start. But once they remove that stress and they find a distraction, then labor starts. So again, there's that, create a positive distraction. So I always just tell ladies, like, plan a party or plan a date. Babies like to mess up the parties and the dates. Like, they like to get in the way of them. So, but they're good mess. They're like the perfect thing to have instead of those dates. Cleansing the bowels can also stimulate labor contractions or get labor going, but you want to make sure that you talk to your caregiver before you do that, and any of these things, of course. We have what we call the midwives brew here, and it is super effective. Like, there's a high, super yummy. Some people hate it. Some people don't mind it. Some people don't mind it. Some people, we get a variation of responses on the midwives brew. But some people throw it up. Some people just like, oh, I didn't think it was that bad at all. So just really from woman to woman but the one thing about the midwives brew, I just want to state, and I'm sure that your midwife will tell you this when she gives it to you, that we have noticed that we've super speedy deliveries for a lot of them, a high percentage of ladies who take the midwives brew, especially if they've had a baby before. So so much that they'll take the midwives brew and they'll say, oh, I'm not noticing anything. Several hours will go by, and they're like, well, I'm kind of contracting here and there. I notice a little bit, and then we'll say, well, okay, just don't let it go too far. And we'll, another couple hours, and we'll say, why don't we just come check on you? And we get there, and they're like 8 or 9 centimeters, or even 10 centimeters. We barely make it to deliver their baby. So this is a really common thing with the midwives brew. Like I said, especially if they've already had a baby. But even some first-time moms, I've noticed this. We've noticed this with. Again, remember that baby sets the pace, and you decide how it will happen, and baby decides when. So with some exceptions, of course. Okay, as long as it's problem-free, intervention in any form is unnecessary. It's your birth done your way. Okay, your body working with you and your baby, cervical effacement. I'm just going to go over this really quick. Again, these are the hormones working for you to get birthing going, for labor. Progesterone, estrogen, oxytocin, prostaglandin, relaxin, and that's most of them. There's, of course, others minimally working. So this is the cervix closed. This is the cervix about 1 centimeter dilated. This is about 5 centimeters, and this is complete in dilation. So I just like to show that. I think it's a really good. If you're wondering, because a lot of women are wondering, like, am I really in labor? Is this really labor? And this is, something that we are familiar with, and you probably would have to have it memorized to know. But this, in case you wonder what we're looking for, these are some of the things that we're looking for when we check on a mom, if she's wondering if she's in labor or not. So we're going to look at what her dilation is if she allows a vaginal exam. We're going to look at the effacement. So if she's about 3 to 4 centimeters, let's just say if she's about 1 to 2 centimeters and maybe, around 50% effaced, and the baby, the station, we'll talk about the station in a little bit more in detail in just a minute, but the station of baby is maybe station 2, and then, or maybe even 3, and if baby is posterior, the cervix, if the cervix is posterior, so let me show you guys really quick. I think I might have shown you at one of the classes, but I'll show you what a posterior cervix is, in case you have it said to you in labor. Or if you wonder if you're in labor, your midwife comes and does a cervical exam, and she says your cervix is very posterior. So I couldn't really check to see what your dilation was because your cervix is so posterior. So here's your cervix, okay? So of course the midwife is going to insert through the vagina, and then she's going to be feeling for what the cervix is doing, okay? And if a lot of times, and I think it's a protection for the baby and for the mother to not go into labor too soon. The cervix, for a pregnant mother, especially around 37 weeks plus, is going to be moved back here closer to the rectum. So it's going to be moving, it's going to move back here. So when we go in to check, a lot of times we can't reach it. And I have long fingers, and sometimes I can't reach. And it's just clear back there, and we can tell that it's firm, but we can't feel the opening. And so that's what a posterior cervix is. So if the cervix is posterior, that's usually a good indication that labor is not at least that day, or maybe not the next couple days. So, but the cervix does move forward for labor in most every case, especially if, did I just move it a bunch? Especially if it's a labor that was allowed to start naturally. I did lots. Okay, sorry. Hi guys, sorry. I was just pushing it, huh? Okay, so we have some guests. I'm going to show, let's see. Okay, we'll just pause right here for a second and just have a couple guests really quick and talk about their birth.
We're early, so.
Oh, are you? Good. Because that was like, are we already 7:30? Okay, do you guys care if I just go through a couple more slides and then we'll just, okay. All right, so the relaxin hormone is softening those tendons, it's softening, the ligaments and allowing your pelvis to stretch and move. And this ligament right here, in between the pubic symphysis, actually moves open. So a lot of times it's pretty painful for mothers. They notice more pain and tenderness in their pubic symphysis. but it actually moves open and expands to allow baby to move down and through, and it's really fascinating. And so I'm just going to talk really quick about the fontanelles. So you can just ignore all these other words, but I'm just have right here, I just want you to notice these fontanelles. This is what we look for when we're doing a vaginal exam and we're trying to fill position of baby. We try to fill for this fontanelle right here. This is the anterior fontanelle. The posterior fontanelle. And this is the anterior fontanelle. So it's a little bit confusing, but if we fill the anterior fontanelle, then that's a good thing, but we don't want baby to be, I'm getting mixed up. If we fill the posterior fontanelle, that's a good thing, but we don't want baby to be posterior. So just in case, but it's better if we don't fill this anterior fontanelle, but we do want baby to be turned anterior. So hopefully that makes sense. And I'll show you really quick on this baby as well. So this is what we want presenting through, and I don't use this baby for birthing because it's very stiff and your baby's not going to be like that. So this is what we want presenting, like this is what we want to fill. You can see that posterior fontanelle. This is the optimal position for baby. And so if this was presenting the anterior fontanelle, then most likely baby would be posterior, or face presenting, or military. So we want those. The relaxin hormone also softens the baby's ligaments, makes it so babies can move through the birth path because it's so tight, and it makes it so the baby's skull can actually fold over the top of itself. So it's really, really neat. I'll show you in this next one. Where did I put my clicker? So you can see that the plates on the baby's skull are not fused together, and that's where those fontanelles come from. And it folds over itself as it's moving through. The skull folds over itself, those plates do, as it's moving through the birth path. It is so incredible. It is so fascinating. You can kind of see here what it's doing. So as baby's moving down and through the birth path, you can see that part of the crown of the head is going first, and it's moving up and over. So it actually, these are like the plates, so it's actually going like this. It is so neat. So when you see baby, mother pushing, and you see baby, the crown of baby's head presenting, and you can see it through the pushes, then it looks like this ridge. It almost looks like the baby's nose is coming. So somebody who doesn't know, what it looks like for a baby to be born vaginally, then they'll be like, oh, that's the baby's face, and it's actually not. It's just it's really pronounced ridge there on the top of the baby's head. And then as soon as baby comes out and baby's head is out, or even as soon as baby crowns, then you can see those plates. You can actually see them move down, and it goes smooth again. So really fascinating. Okay, so I just like this. I put this up here, and I don't know if I already talked about this, but sometimes your body's compared to the medical world, and they say, why would you want to do this without epidural? That's so painful. Why would you do this? It's everything natural. And just like you wouldn't, compare it to, some people compare it to, trying to fit a grapefruit through your nostril. And that's not a good comparison, because your nostril is not meant to stretch and that big, but your perineum, your vaginal walls are meant to stretch like that. They're designed to, and then to go back. So I just think, just keep that in mind. Yes, there is something that is going to be a lot bigger than you're used to, way bigger than you're used to, coming through your birth path, through the vaginal walls, and then out through your perineum. The hole that's normally that small, and then it's going to stretch, bigger than that to fit, or around that size to fit baby out and through it, And for a lot of women, it's just very scary to think of, but if you just think of it as like, my body was designed to stretch like that. My body was designed to be elastic and smooth and stretch like that. Okay, I'm not going to read over this just for lack of time. It's not in your book. It's just something that the lady who does the classes with me put in there. It's really good though. Maybe if we had time at the end, we'll go over it, but I kind of doubt we're going to have time. So I just like this. She threw that in there. It says, you know, are you stuck or committed? What are you going to do? I won't do it. I can't do it. I want to do it. How do I do it? I'll try to do it. Okay, I can do it. I will do it. And yes, I did it. So just change your mindset. It's just really just making sure that it's up to you. It really is up to you ultimately. Barring special circumstances, it really is. Many people are passionate, but because of their limiting beliefs about who they are and what they can do, they never take actions that could make their dream a reality. So I just like that this was added in there because there are a lot of people who just allow their limiting thoughts to dictate how their life goes and even how their birthing goes. So, okay, we're going to have our guests now. This is Brent and Lexi and Valak, their little boy. If you guys want to come up, I'm going to turn this light on. It's going to be bright. Sorry. Wake everybody up. They're just going to talk about their birth, and then if you guys want to ask a couple questions. We have to cram a whole bunch of information in, so we're going to be quick. But if you guys want to stay for some food, you can.
Hi.
So Brent, Lexi, Valak, this is our class.
Hello.
Not sure.
I know, it's like, I don't know how to start.
No, that's okay. So where'd you birth?
I was at the hospital.
We chose the hospital because she had previously had an ectopic pregnancy,
I had so many miscarriages, I just didn't want to chance it.
and things were a little bit higher risk, and so, but we hired Shauna to be our doula, so we kind of got the best of both worlds. We had her at the hospital, and she coached us through everything. And the hospital was really good about letting Shauna do her thing, which I'm very grateful for. And you can be fairly forceful about what you tell the hospital you want to happen. So that was good.
I don't remember a lot of it, so. I
So
know, like,
your
I'm
water
trying to
broke,
think.
right? Your water broke. You had some.
So,
And you were how many weeks?
I was 37 weeks, my water broke, and I didn't have any contractions until around probably 7, but they're really, really light. And then,
And 7 in the morning.
yeah, 7 in the
Yeah.
morning, sorry. My water broke at 5 in the morning, so I didn't have contractions until probably around there, only heading to the hospital, but after the hospital, when we got there, I didn't have any more contractions. And
So we did midwife's brew with her. I hope
Yes.
that's okay that I
Yeah.
she had to sneak midwife
I
through.
snuck it in. I snuck it into the hospital.
She had to act like it was her drink. They wanted to induce me because nothing was happening, but finally around I don't know. Did you say like maybe around 3? I don't know when I actually started.
What time was he
contractions.
born?
He was born the next day at 7:30 in the morning.
Yeah, so it was a pretty long labor, but for the most part, it was completely natural. No epidural, no painkillers, no anything really, and it just worked. It's very important, and Lexi was really good at listening to Shauna's coaching advice about breathing. He came early, and so
I never
she
practiced.
didn't practice. That's not
But
what
she
needs
was
to happen. She
very
needs to practice,
responsive.
but as long as you're willing, well, she was able to listen to Shauna's coaching and breathing advice, and everything just worked out really well. It's important to, during contractions,
It's important to breathe through it, not hold your breath in time, because if you do that, it makes it so you don't dilate as fast. So when you breathe through it, it helps you dilate faster. At least that's what I remember you telling me. So that helped me listen more. But
So we'll have one of each.
No, I wanted home for both of them, but we thought it would be safer also having my parents say, it would be safer just do a hospital kind of thing, so I did. But this time I'm like, no, I'll do it at home.
It was our first. Just
So,
wanted to be on the safe side, but
Especially with your experiences.
yeah, with
hospital, it wasn't bad. It was
Yeah.
just
actually went really well.
wanted to go
Um,
home.
much better than I could have asked for.
Oh, yeah.
The nurse didn't even come in. She barely came in. And I think it's also because they knew Shauna, so they knew.
Yeah, they just kind of let me do my thing, so, which is nice. And you lucked out. Like, sometimes you get those nurses if you're in the hospital, and sometimes you don't. But this nurse was great. She's just like, oh, Shauna's got it. So
Even
so
the
she,
second nurse that came in,
Yeah.
or her extra,
Yeah.
she didn't even care either. So.
so and Lexi's got it. I didn't need to give me the credit. Sorry, you got it. She could tell how well you were doing. Like, so a lot of times they'll come in and they'll give suggestions and like, can we do this? Can we do this? Can we do that? But you know, they could tell that we had our team. We were just doing our thing. She was doing amazing, and so yeah. But yeah, thank you.
Apparently
Thank
I
you so
did amazing.
You did do amazing. It was
that,
long.
I was like, oh, okay.
Yeah, so one of the reasons I asked them is because it was your first baby, first birth. It was unmedicated and it was long. It was long, but you did so well with it. Like, that's one of the things I thought was so awesome. She did so well. She was very responsive to promptings and encouragement, and Brent was so supportive to her, like super supportive, just like on it. And, and I thought that was awesome. Like, so, but like there are, first time births, a lot of them are just long. And so this was just a really good example of a long birth that turned out really well. So anyway, thank you guys so much. Are there any questions? Are there any questions for?
Well,
Yes,
hospital?
It was Riverton.
Virgin.
Yeah, the hospital, that's where you go.
And a lot of times it does depend on the staff on call when you're at the hospital, even if, sometimes it's a different story, the same hospital. But yeah, so we'll just take a break right now. I'll set some food out. Thank you guys so much. So 3 stages. The first stage of labor and birth is the thinning and opening stage that begins with the onset of labor. This is when, oh, thank you. Thank you so much. This is when you know this is labor, okay? Maybe after the midwives come to your house a few times, maybe 1 or 2 times and then left because you weren't really in labor. It was practice labor, so this is what when we're talking about here, this is real labor, okay? Can we turn this off now? Are you guys okay with? I need to figure out these lights. Okay. There. Okay. It's divided into 2 phases. The first is the early or latent phase. That's when you're about 1 to 4 centimeters in dilation. So about, more likely about 4 centimeters, so in between here. So this is about 5 centimeters is if I took my fingers, like a peace sign. Peace sign is 4 to 5 centimeters, so that circumference. Okay. And then there's also that little booklet you guys can look at again if you want before you leave. And then 1 to 4 centimeters in dilation, but usually 4 centimeters, around 4 centimeters is when we can kind of tell, okay, this is, mother's in labor. At this time, I highly recommend that you stay busy, stay distracted in this early phase of labor. And some women even just are in denial about labor, which they just kind of pretend like I'm not really in labor. And you just keep doing things. Like the sooner you go to where you're going to birth your baby, the longer and more drawn out it's going to feel. So the more distracted you can be, the better. Of course, you don't want to push that too far, and you for sure want to let your midwife know that things are going on, and most likely she will know because she'll be telling you, yeah, you're in active labor. So active labor ends at 4 to 8 centimeters dilation, and it ends with what we call transition. So you're transitioning from the normal surges to the birth breathing surges. Possible signs of your labor onset is that uterine seal dislodges. That's a thick or stringy or whitish blood-tinged discharge. So when you go, a lot of women notice it, some women don't. So when you go sit on the toilet and you go to wipe and you have kind of like a glob, like your normal discharge, but in a glob, and then it's tinged with blood. It's about a teaspoon or more. It shouldn't be more than a tablespoon of blood though. Some women have a little bit more than others, but always let your midwife know or your caregiver know if you notice this. Membranes release, your water breaking, that could be a sign that you're starting in labor. Sometimes women have their water breaking with contractions, and sometimes there's no contractions at all. So it's not always like it shows on the movies, like if your water breaks and then all of a sudden buckle over and you're in hard contractions. It's in fact oftentimes not like that. So we definitely want to get things going if your water breaks and you don't have contractions. A feeling of being so start of surges, sometimes you won't have any of those signs, and your surges will just be more intense and coming more consistently and lasting longer. Feeling of being constipated, pressure from the baby moving down closer to the birth path, and baby's head pushing on the rectum, that kind of gives that constipated feeling. Or sometimes it's the opposite and you'll have really loose bowels. And that's nature's way of kind of just getting things out of the way for baby to come. And sometimes none of this happens, and it's rare, and you just don't really notice anything, but you just have this sense that something is different. And this actually has happened where women have called the midwife and they're just like, I don't know, I'm not really contracting, I just have this weird pain in my back that kind of comes and goes, but it's not really intense. Something's going on. So we'll go and assess, and that mother is like 8 centimeters dilated, and for some reason or another, when we get there, all of a sudden she does start feeling her contractions and they get intense, and we have baby very soon. That's really rare, but just always just pay attention to things just being off. And the more in tune you are with your body, the more likely you can notice this if you're one of those rare cases. This is a really good time to relax and to just get in that deep relaxed state. Even if you're busy doing things, you can do that. So as labor moves along, gather your items together that you're going to be needing if you're going somewhere other than home. Some people, even if they're doing like a home birth, they'll go to a friend's or a family member's house to birth. If you're going to go to the hospital, make sure you have your stuff ready to go. Hopefully you'll already have this stuff ready, but get it to the car at least. Begin initial hypnosis, reading or listening to scripts, whatever works for you to relax. It doesn't have to even be either of those things, just whatever helps you to be in that relaxed state. Continue during the, already talked about scripts. The birth companion's prompt card, you could review that I just handed out. In your booklets, there's a little handout that says 100 ways to cope during labor. So it gives a list of 100 things. So review that. Look over that ahead of time. Don't wait until you're in labor to look over that, because you might get some ideas of some things that will help you during labor that you can use and have prepared in advance. So during your surges, use the slow breathing, of course. Remember the balloon breathing. I can't emphasize how important that is to fill up that lower abdomen with your breathing. Don't pant or hold your breath. Use the visualization to help your labor progress. This is so helpful. Visualization. Women actually visualizing their cervix, moving, softening, opening, thinning, all of those things. It's very effective, especially during the surges. So in between the surges, if you're resting, if it's at nighttime, we recommend sleep. Like even if you're being woke up every couple minutes or so, or every 10 minutes or so, still try to get that sleep if it's at night. If it's during the day and you don't feel tired, then you can just stay busy and continue doing, your daily activities. Some women like to go for a drive, just don't go too far, but keep in communication with your caregivers. And if they're not there with you, and just do what helps you stay calm and at peace, and whatever releases tension. So at the end of this early stage, it's when you're about closer to 8 centimeters, you're going to start feeling that urge to push, come and go. Some contractions you'll kind of feel like an urge to push, and some of them will just feel like normal contractions. But then when that does, you can start getting ready to breathe baby down, and you make sure that you're allowing those breaths to go down and around baby. So again, birth companions role. I'm going to read over these really fast, but they're in the prompting too. But this is so, so important. Even though I'm going to read it fast, just pay attention. Suggest water consumption or snacks. Position changes every half hour. Also, midwives, doulas, support, other support people will suggest these things as well. But sometimes husbands notice it more, like if we're busy doing other things, than we will, especially if they're really in tune to the mother and what's going on with her. So, light touch massage, cool face cloths, effleurage in the bathtub. When a mother wants to go rest in the tub while she's laboring, we always send husband in there and go be with her, go support her, unless she doesn't want it. There's some times where the mother doesn't want, and they're like, no, send in the doula or send in the midwife. But that's rare. Placing pillows where needed is also really helpful. I recommend lots of pillows, like 6 to 8 or more pillows. That we can't emphasize enough how beneficial lots of pillows are in birthing. We've been to births where they've had 1 or 2, and we have to get really creative, like how we can prop the mother up and support her. So lots and lots of pillows, even if you have to go buy more. So a birthing mom will often not remember what she previously decided and the choices she made. So it's sometimes, a husband's there to be like, hey, remember we talked about this? Is it okay if things change? Are you, how you doing? Things like that. How are you doing with what we've decided? Be extra loving and reassuring to her. Help her out often. This goes very far in helping labor to continue to progress and mom remaining calm, relaxed, and focused. And a note to the mothers, communication is key. If there's something going on in the birthing that you're not comfortable with, you have to speak up if someone else doesn't speak up for you, because we can't read your minds as much as we try to. We read body language, we try to be in tune to what the mother needs, but there's some times where we just can't tell for sure what you need, so you got to say. Okay, and then also you want to make sure the interventions are not needlessly imposed. You husbands, of course, midwives, doulas can do that as well, but it's also even more helpful if the husbands do it. Sometimes in the hospital, if a doula speaks up for a mother or a midwife speaks up for the mother, they just kind of look at them like, who are you and why are you saying anything to me? But if the husband speaks up, then they're like, oh, okay, we'll be more willing to listen. So help to make sure preferences stay in place, again, in a non-confrontational way. And that can apply at home as well. Just more cervical dilation, visuals, just to help. Early phase of labor, again, 3 centimeters. This is not actual size, but you can kind of get an idea of what the cervix is doing. Active phase, when it's going, labor is like past that 4 centimeters, possibly more into like 6 or 7 centimeters, and your contractions are a lot more intense. They're lasting a lot longer. 6 to 7 centimeters right here is about when mothers know that they're actually going to do this. This is really happening. I'm really doing this here at home, or I'm really doing this in the hospital without an epidural. That's usually when they've made up their mind, because it gets very, very, very intense at this stage. So true. This is just on here really quick, just even though it doesn't have to do with the cervical dilation, it's just something that's helpful. True labor contractions come regularly and they're close together. They reach your lower back and upper belly, and this is in normal cases, most cases. They last from 30 to 70 seconds or even 80 seconds, and they get stronger as time goes on instead of kind of staying the same or dying off. Okay, sorry, actually, a good way to tell if it's true labor contractions or not is actually to do stairs. So if you think that you're having labor contractions and you think you're in good labor and it's active, it's they're coming in, the contractions are coming in a pattern, or the surges are coming in a pattern, and you're like, hey, is this real labor? It's really interesting. But a lot of times if a mother will go and walk stairs, and if those contractions pick up, they come a lot more intense and they get a lot more frequent and last longer, then you're like, okay, maybe this is labor. But if they kind of die off or or even going for a walk. Sometimes we'll do this too, or getting in the bathtub. So those are some good ways to kind of tell. But a lot of times it's the stairs for some reason that tells us. But it can be the others as well. Okay, so stage 1, this is what's happening in stage 1. This is the early latent phase. Baby's still up high. That cervix is starting to open and thin. And then here we have the active phase. Baby's moved. You can see baby's moved down further into the pelvis, and that cervix is opening even more. And it can be opened even more so than that in the active phase. And then transitional phase. And this doesn't show it open further. It would feel more open than it shows here in transition. Unless baby is, so a mother can be 7 centimeters and baby just be really, really low, and mother start feeling that urge to push. And so it's really important that if you start feeling that urge to push, that you allow, if you're open to it, if you allow the midwife, and you just feel like this is so strong, I just feel like I need a push, you allow the midwife to just do a cervical exam and see if your cervix is actually out of the way. Because if you start to push on a cervix that is not completely dilated or effaced, then it can make it more tense and tighten and cause more pain and be hard for the mother and the baby. So
would you have more chance of tearing because of it?
yeah, more chance of tearing as well. It will just prolong, and it would make labor harder anyway. So it would just prolong things. But there are also, having said that, there are also ways that we can kind of tell that it's a lot of times, not always, that we can kind of tell if a mother is actually completely dilated. There's certain verbal sounds like moanings, the tone that a mother is using, her moaning changes, her body language changes, that kind of gives us an idea that this baby is really low and this baby is really close, instead of mother just feeling like she needs to push. So putting that in there in case you just absolutely don't want a cervical exam. There's other ways that we can kind of tell. Okay, what are my options if labor stops or slows down, which does happen often in labor? Avoid intervention if possible. Have patience. Ask for the patience of others. 50% of labors will restart spontaneously within 24 hours. Very, very, very rare cases, a mother will get to like 8 centimeters. I've only heard of it twice. Actually, one mother was 10 centimeters dilated. She went 2 weeks. 2 weeks, and then she had her baby 2 weeks later. It was really crazy. I've only seen that once ever, but another mother got to 8 centimeters. Everything stopped. And then both of them still had their babies at home, too. Everything stopped. She just went about her life and daily activities, and a week later, she had her baby really super fast. But super rare. But aside from that, mostly your labor will not stop completely. So that's in all the time that I've ever been a midwife, 16 years, that's the only time I've ever heard of it. And my colleagues as well. It's the only time we've ever heard of that. So some things that you can do is don't be pressured to speed up labor, no need to rush labor along if there's no special circumstances. So if mother and baby are doing well, then we don't need to speed things along. A lot of times if you just remove the stress or relax, and remove stress I mean by sometimes remove people from the room, and relax. Labor is just as much emotional work as it is physical work. Like I said in the last class, sometimes we'll send people on errands, like to just kind of, or sometimes even us as midwives, if it's been a really long drawn out labor, we'll say, we're gonna go for a drive. Like we remove ourselves from the room. We're going to go for a drive so that you just feel like you don't have to perform, like you don't have to keep labor going, you don't have that pressure, because sometimes women do have that pressure to keep labor going. So we'll get in the car, and they're like, oh no, don't leave, what if, we'll like, no, we'll stay close. So we get in the car, we go for a little drive, and then, sure enough, within an hour, they call us and like things have picked up like crazy. Mother's feeling a lot more intense contractions, they're closer together, they're lasting longer, and so a lot of times it's just that change of scenery, that change of pace that helps. Approach it with fun instead of urgency. Use humor and laugh. Laughter creates endorphins, and that breath is thrusted downward, which can stimulate the contractions and kind of moves baby down more onto the cervix. Change of scenery can oftentimes get labor going again. So sometimes we'll send mothers on a walk or a drive if labor's been going for a while and things kind of slow down. Resting in the tub while using visualization and meditation is very helpful. Use deepening techniques to bring mother more relaxed. Guided meditation and visualization. And I said on here rest, but like sometimes we'll just tell a mother, why don't you just go lay down? Like if she's been up walking around, if she's been on the ball, if she's been leaning against the couch and doing different things, just laboring actively. And then we just say, why don't you just go lay down and try to get some rest? And they'll say, well, I can't sleep because they'll just keep waking me up every 2 minutes or every 30 seconds. I can't sleep. And we'll just, even if you wake up every 30 seconds, just try to rest. A lot of times when a mother goes and rests for about a half an hour, sometimes even 2 hours, then all of a sudden that labor just picks up like crazy, and sometimes water breaks and baby's here right away. So if the mother can rest and like truly allow herself to rest, a lot of times that's all that's needed. Light touch massage, release more endorphins and oxytocin. Those are good ideas. And then have daddy talk to baby. Huge, just like I was saying in the other classes, babies listen to daddies. So I have one example. There's actually lots of examples that I have, but one story that stands out the most is this dad was this big burly guy. It was the birthing. And I don't remember if they knew the gender of the baby or not, but they kept calling the baby a girl. And I think that they were just guessing that it was a girl. I don't know. I think everybody just thought that the baby was a girl. But this mother had been laboring for quite a while, and then and the baby was coming military, so coming top of the baby's head, presenting that way. And this mother got to 9 centimeters and just was working like crazy. She went and got in the bathtub, and the midwives and doula had done everything that they could think of. And so the midwife came out and she said to the dad, and he had this big booming voice, and she said, do you have any ideas? Is there anything you do? Can you just go talk to the mom and the baby? And so he's like, yeah, I will. And he opens the door. He's like, first of all, he's like this loud booming voice, and the mother's in the bathtub relaxing, trying to just relax so that she could move along and get to 10 centimeters and be able to push baby out. He's like opens the door. He's like, first of all, everybody's calling this baby a girl, and it's a boy. He's like, son, tuck your chin and come on out. So, like literally within minutes, that baby was born. So, babies listen to daddies. Okay,
Was it a boy?
It was a boy. It was a boy. So, okay, so misconceptions about labor. Breaking your water will help move labor along. A lot of times we're asked over and over at a birth, please will you just break her water? Like if it's a long birth, will you just break her water? I think it'll just move things along. A lot of times it's by a mother, like the mother of the birthing mother, or an aunt, or sometimes a sister or a friend. Can you just break her water? I think it'll just move things along. And it's not even 50% of the time does that happen. So it's a really hit and miss. Sometimes it'll move labor along, sometimes it won't. But it's so much better for mother and baby to keep that water intact as long as it stays intact naturally. Just like I mentioned before, it's a natural shock absorber. It contains salt water, glucose, and endorphins for the mother and for the baby. And if the water is broke, it's almost always more intense for the mother and the baby. In fact, it's so intense for the baby that when the water breaks during birthing, spontaneously, we will check heart rate right away to make sure baby's handling it okay. So most of the time they do, but we just want to make sure, and then we'll monitor it more frequently than we would with the water being intact, with the membranes being intact. So another misconception is that if your membranes release, infection is imminent. You're going to get infection. Like a lot of times the hospitals have that mindset, you have to be on antibiotics. If your water breaks, it's not necessary. You can check mother's temperature, and you can keep checking her blood pressure. You can check baby more frequently, like we do. Your cervix isn't stuck. I know of ladies who have actually been told by OBs that their cervix is stuck, and they can't, their cervix won't dilate, and they can't have a baby vaginally, and they have to have a C-section. This is not true. There's like maybe less than 1%, far less than 1% of people that their cervix won't actually dilate. It's just you need to look at different measures, a lot more things, and mother needs to be allowed the time. So labor needs to be restarted immediately if it stops. Again, not true. Just give mother patience and allow rest, and it will restart. And then you can't rest in the tub if your membranes have released. That is not necessarily true. You just want to make sure that if your water's broke and you want to be in the tub, that it's an really, really clean tub. Just make sure it's super clean. But and we will reduce vaginal exams as well. Okay, helpful pressure points. I'm going to show these really quickly. These are super helpful if you guys want to take a picture of this, because it's not in your book and it's not in the booklet. Just something that I've added in there because these are things that we use really often during labor, and not every woman. It's not helpful to every woman, but most women, and a lot of these are. So supporting a woman while she's standing, maybe lifting one chair up and rocking and doing lunges to help rock baby down. Kneeling over the back of the bed or a chair, double hip squeeze while mother's in hands and knees position, or any position, really, unless she's on her side, then we can squeeze on one hip. Counter pressure, all of these are actually counter pressure. All the ones where it shows the assistant giving pressure, they're counter pressure. Open knee chest position. This is something that we would get a mother in if we're wondering if baby is in a posterior or asynclitic, that's baby's coming like this, or military, and baby needs to just kind of back off the cervix so that it can have time to turn. And usually we'll use what we call a rebozo for that, kind of shake baby's belly and kind of move baby out off the cervix to get in a better position. And that's usually if a mother is experiencing a lot, like intense back labor that she can't handle at all. So knees, back, and hips. So these are very, very helpful, but I just want to put in there that a mother who is very relaxed and very calm and very in tune with her body and open to prompts doesn't feel like she has to have these for the most part. So there's women who just like are constantly feeling like if they don't have the pressure that they can't handle anything. And then there's the women that are like, okay, well, yeah, the pressure is helping, but I want to try and handle these surges by making sure that I'm staying relaxed and calm. And oftentimes those mothers who do that, and I'm not saying that we don't want to give this help. We love to give this help and support. But I'm just saying the women who just feel like they can't do it without the pressure points, the counter pressure, and then their labors tend to go longer. So, okay, positions for laboring. Again, just a bunch of them. If you want to take pictures of these, it's just some ideas. I'm not going to go over every single one of them. We've got the tub in here, laboring. The tub is super helpful for a lot of women. And then benefits of laboring upright. Gravity is working for you. The labor time can be decreased. Pelvic space can be, so the pelvic space, so the opening of the pelvis is increased by 30% if you're laboring upright than if you're just sitting or lying down. Contractions are usually, so really quick I'm going to show you, this is the pelvic inlet. Okay, you can see it's much bigger, and this is the pelvic outlet, and it's much smaller. Okay, so laboring upright opens the pelvic outlet so that it's bigger. But you want to be careful, like what stage or position your baby's in, what station your baby's in, because sometimes if it's up too high, but that's why you don't have to remember all this. That's why you have the doulas and the midwives there. Sometimes if it's up too high and that pelvic outlet, or inlet, sorry, outlet. I'm saying it wrong. Pelvic inlet, sorry about that, is too tight, then it won't let baby move down. So you want to make sure that's opened up. And there's different positions that you can get in at different stages of labor to help the inlet and the outlet open up just right to let baby move down. but there's just not time to allow for that here. So the contractions are usually more effective if you're laboring upright, generally easier to move and to get comfortable. The better back and side access for the counter pressure, lowers the risk for medical intervention. Benefits of laboring in water can reduce the pain, acts as a cushion for surges, increases comfort level, easier to relax and rest. And this is for most women, not everyone. Some women, they want to get in the water and then they get in there and they don't like it and they're just like, I just have to get out. Even if they love baths and they were looking forward to a water birth or relaxing in a birthing pool, and then they get in and they're there for a little while and they're like, oh, I just have to get out. So husbands, if you set up a big huge birthing pool and you get all the water filled up and you have it all heated and everything, and then she gets in and she's only there for 5 minutes, don't be mad at her if she decides that she does not like it at all, because that does happen sometimes. It conserves energy for the most part, as long as the water's not too hot. It gives a greater sense of control, and it can reduce the perineal trauma or perineal tears. So having said this, with the laboring upright, if you're tired, don't feel like you have to push yourself to labor upright, that you have to stay upright. If you're tired, go rest. It's so important that you allow yourself rest when you're laboring if you feel like you need it. Okay, labor and birth stage 2. So this is when you're going to change from those normal surges, those normal contractions, to those birth breathing contractions that I showed you last time. It begins when you're fully or nearly complete in dilation, this stage does. And baby's head moves into the birth path, and it ends with the birth of your baby. Stage 2 of birth ends with the birth of your baby. So when you're getting close to this second stage, these are some signs that you're getting close. Your depth of relaxation gets deeper, and most women will tune out the room. They're not really as responsive. They will maybe give like little sounds for answers, or one words or grunts or something. They're not very responsive, especially if they're super deeply relaxed and calm. They're just tuning into their body and their baby. A lot of times an amnesiac state sets in, like I was mentioning. Mother and baby are working together. You're going to feel a intense sense of fullness in your pelvis, like down low. It's very common to hear mothers say, I need a poop. Like, I've got to poop. Or they'll go into the bathroom, because we'll be sending mothers to the bathroom often, and they'll go and they're like, there's nothing. And we're like, okay, well, that's baby's head. Baby's head is pressing against that rectum, and it makes the mother feel like she needs to poop. So that's a very common thing to tell that mothers will say when we know mothers are close. Let's see, sorry. The breathing begins to change from the slow breathing to the birth breathing. So you'll have those surges that'll be feeling more often that feel like you need a push, and then some of them just normal surges, and then more of them feel like you need a push. It's really important to wait until you feel that urge to push with every single contraction before you start pushing. It makes it so that pushing time or birth breathing time doesn't draw out as long. Some women will be encouraged, even if they're fully dilated and fully effaced, they'll be encouraged to start pushing, and it can make their pushing last longer. So and they don't have that urge as strong. It isn't as intense and as involuntary if they don't wait till it just builds and it's really, really strong. So it's really helpful. It'll make your pushing time not be as long as it would have been if you just let that build and get really strong. Another sign that you're getting closer to your birth breathing phase is more bloody show on the Chuck's pads. So we will have Chuck's pads laid out, or in the hospital they'll have Chuck's pads laid out, and mother will be sitting on them, doing various things, and they get up and go to the bathroom, and when she gets up, we'll notice some blood tinged, more than just that mucus bloody show blood. It's like quite a bit more, not like actively bleeding, but just a good amount of blood on a Chuck's pad. And that's a really positive, encouraging sign to us that things are getting really close, because baby's head pushing down past that cervix pushes out blood down through the vagina and out through the perineum, and it means that baby's getting really low. Sudden urge to escape or feeling of being done, that's really common. A lot of women will feel like, okay, I can't do this, I'm done, I need to move, everybody needs to just take me somewhere, I have to go, and I'm like, you know, a lot of times that will be said, it's just so intense, and they just want to go, they want to leave, don't touch me, don't do anything to me, don't talk to me, and they just need that extra encouragement, like, okay, you can do this, you know, and that means your baby's really close, and it's just so intense, there's so much pressure, it's so, your pelvic floor feels so much pressure and weight and fullness that it's very intense. It's very, very important at this stage that you listen to the prompts of people in the room who are there to support you, and you listen to that guidance and follow those and get back into that relaxed state and remove yourself from that panicky state and allow yourself to just be relaxed and calm so that baby can move past that intense area of where it's in and move into that birth path and start pushing baby out. Sometimes when you do get to where you are actually complete and you're ready to breathe your baby out, then a lot of times mothers will have all the contractions stop, and it's just not anything to be worried about. It's just your body's way of giving you a rest that you need for that pushing phase, for that birth breathing phase. So right here, you can see that baby has moved past the cervix, down through the birth path, and is crowning. So this is what we call crowning. And when this happens, it's really, really important that you listen to the prompts of your caregivers, doula, midwife, whoever's there, and don't push. You're going to be pushing and pushing, pushing. Baby's going to get right here. And then you're going to want to just push because you want to be done. But it's really important to allow baby's head to just sit there and that perineal tissue to just stretch around baby's head so it reduces the chance of tears. And if you allow that and you listen to the promptings of the people and the direction of the people who are there to support you in the room, then if you allow that baby's head to just stretch that, you have a lot less likely to tear. Okay. So these are the stations that I was telling you about. So this is when a baby, so these, I won't go over all of them, but just floating means that baby has not got quite to, so baby floating, I'll just go over it here, sorry. Baby floating is like this, okay? So that's floating, okay? And then as they go deeper and deeper, this is engaged when baby's about mid-pubic bone, okay? That's baby engaged. And then as baby goes down further past that pubic bone, and then these are the different stations. So this would be like a plus, this would be like a +3 right here, +4, +5, and +5 is actually crowning. So, or even +4, depending on who you're talking to. So those are the stations in case you hear one of your caregivers tell you, baby's at this station. Sometimes that's helpful. Again, evidence on birthing upright. I'm not going to read you more of this, but if you want to, you can take a picture of it. I just wanted to show this cub. This is something that we found in the last 3 or 4 years that is incredible. We love it. This is the hard birth stool that I was talking about in one of the classes that we used to use for mothers who needed to be in a semi-squat for birthing because semi-reclined was just not working and baby was not moving. The pushes were not effective. And so we'd get them on this and it was not comfortable at all. And it was very hard on mother and baby. And it actually increased chances of tearing because it was so hard. But now we have this, and there's been many ladies who have delivered with this, just sitting up, and baby's it's shaped kind of like a horseshoe. So baby can just come right through there and have the support of somebody behind you. And you can do all these different things with laboring. So we have on our team several of them. We bring them to the births in the hospitals. They have them now. They're just great. They're awesome. So you don't have to worry about getting them. But I would still recommend a yoga ball because there's other things you can do with the yoga ball that you can't do with those cubs. That's what they were called, the cubs. So birthing your baby, dilation's complete, breathing baby down and pushing. So presentation of head, crowning. This is what baby is doing, and it's going to move, and baby moves itself. We don't do a lot unless we feel like baby's stuck, then we will get in there and we will manually assist baby if needed, but we just kind of help that perineal tissue to stretch over the crown of baby's head. But for the most part, we just let baby do all this, and it does it naturally. So baby's gonna rotate and move because they're so smart and they just know how to move through the pelvis and out. So there's baby delivered. You can see that the umbilical cord is still attached, the placenta is still inside. So when this some signs that that dilation is complete is mother suggests the need to begin to breathe down. So listen to the caregiver, your midwife, and make sure it's okay to push. Make sure that cervix is completely out of the way. I'm sure that all of you guys have heard like a cervical lip. So if you guys, or most of you if you haven't, a cervical lip is, your cervix needs to dilate all the way around evenly. And if there's a little part on your cervix that is not completely dilated and effaced, thinned out, then that's what we call a cervical lip. And a lot of women don't know that is very, very, very common. Some women are like, oh, I had a cervical lip forever. I had, something's wrong with my cervix. I all my babies, I had a cervical lip. Well, guess what? 98% of women who birth end up having a cervical lip at some point. And so it's really common. It doesn't mean that there's anything wrong with you. It just means that there's just that last little part of the cervix that needs to thin out completely and then just slip over baby's head. Or baby's head needs to slip through it. So that's why we say make sure you listen for your caregiver to say it's okay to push, because we want to make sure that cervical lip is gone. And sometimes we can go in and we can hold that cervical lip out of the way, and we can see if the pushes are moving baby past it, or if it's getting thicker and tighter. If it's getting thicker and tighter, then we'll just say, okay, no more pushing for you. We just need to wait for that to be gone completely. And sometimes us holding it will just slip right over baby's head, and baby can come through and be born. So both things happen. Release all tension when you're pushing. It's very difficult to do, but it can be done. I've seen it done all the time. Remember to lower your jaw, relax it, or remember your lower jaw, relax it and keep it loose. You're going to direct your baby down and up and out in the slanted J. And open glottis pushing is where your neck here is open and you're allowing that energy to go down. You're breathing in and you're allowing that energy to go down around baby, and you're directing baby with those pushes. Deep moaning or groaning sounds are used. Deep breaths at the beginning of each surge. Let the surge gather and build. Super important to let that surge gather and build, and it's really hard to describe this unless you've been there doing it. But once you're there and you're in this birth breathing pushing phase, it'll take a few pushes and then you're like, oh, okay, I think I've got it, and you'll start realizing what your body's leading you to do and be able to do it more easily. Only give the breath or push when effective. Let the surge direct you. So when you feel it build and guide you to push, and then it's going to let go for a little bit, guide you to push again, let go a little bit, and then guide you to push again. And then when it lets go and there's not that urge to push anymore, don't keep trying to push. It's not effective at all. It won't get your baby here sooner. Most cases, it won't get your baby here sooner, and it's just going to wear you out more. So only work with those birth breathing pushes, or surges. Okay, so let's see. And then listen for instructions in case, and especially if there's a special circumstance and you need to do something different. Some women can actually just breathe their baby out. It's very, very rare, but they can actually just breathe their baby out, and I've seen it done lots of times, but most women actually need to push their baby out. So a lot of it, I know I've said it so many times, but a lot of it depends on how relaxed the mother is and how much she is allowing those pelvic floor muscles and ligaments and tissues to just be really soft and open. A lot of it depends on that. And also depends on position of baby and the position that mother is in for birthing too. So, okay, so more about the birth breathing. The slanted J breathing, again, you see the direction that baby moves. to move down and out, down through the pelvis and out. So, like I said, even if a mother is on hands and knees, if she's standing with, I've been to births, not many, but I've been to births before, quite a few, where mother is just standing and holding onto her husband and baby's just born like that. So, again, it's still, that effort is still directing baby down and out. So the slanted J, if a mother's on her side, and I'll show more pictures in just a second, it's always going to be directed in a slanted J, the pushing down and out. Let's see. So this is going to be used at the end of the thinning and opening phase. Position of the baby is a huge factor, more than dilation, like I mentioned to you before. How far down baby is onto that cervix and how strong those urges are to push is more of a factor than how dilated you are. Dilation is important and effacement is important, but it's also where the baby's at. These pushes, you're going to be, the slanted J works with the natural explosive reflex or the fetal ejection reflex. Baby's head presses on receptors in the cervix and later in the vagina, and the brain receives signals to release more oxytocin. That's what gets those urges to push even stronger, is that oxytocin being released even more. And that's that baby's head going down further onto the cervix or past it. This urge to push, or the slanted J breathing, it should be involuntary, like you just can't do anything but curl into it and push. Powerful and intense. It works with the baby for a gradual descent into the birth path. Mother directs her breath rather than the forced purple face pushing, which can create catecholamine secretion and tension. So we call it purple face pushing if you're pushing and it's all in your face or going out into the room, because we'll get some people, and so I'm going to put myself out there and look silly for a minute, but we've got some mothers who are birthing and they're, pushing, and they'll hold their breath and they'll feel it rise and feel it build, the push build, and then they'll, and they'll just get it all out into the room. Or we have the mothers who will feel it rise and they'll feel that urge to push come, and they'll take a deep breath and they'll hold on to it and and you can feel it. And you can feel the difference when you're going, you can feel it out in the room. But if you do it right, you can actually even practice, even when you're not on the toilet having a bowel movement, and you can feel pressure on your pelvic floor if you're doing it correctly. So, I know I look silly, but it's because I love you guys. I'll do that for you. So, it's important that the mother is allowed to work instinctively with her birthing body, remaining calm, encouraged, and supported. So in working instinctively with her birthing body is sometimes a mother is, semi-reclined and she says, I just need to get on my hands and knees, or I just feel like I need to stand up, or I feel like I need to squat. Then we are like, by all means do it. Like, if that's where you feel like you need to go, then do. But having said that, though, sometimes the mother will be in a position and she is pushing, she is doing the birth breathing, and baby's not descending at all. There's no change in baby station at all. And so we will suggest, well, maybe we can get you into this position instead. So, and there's various positions that we can suggest. Well, oftentimes, and especially for a first-time mother, oftentimes we suggest a supported squat, or the cub, or even sometimes hands and knees. Okay, birth, push, or breathe, or push this way only when in a surge, like I talked to you about. Repeat as many times as needed in the surge. Let it build and feel it working. While this is happening, most likely the midwife will be lubricating the perineum, especially if we can see baby's head coming through the perineum. We will be lubricating that area so that it will stretch more easily around baby's head when baby crowns. And that if that perineum is, if we're allowed to work that perineal tissue and use olive oil and just kind of stretch it, it's just very gentle. We'll stretch it and it'll help for when baby crowns, it'll stretch more easily around the crown of baby's head. So it doesn't have to be done. If you don't like it, you can say I don't want it. We don't have to do it. But it's just very helpful, and most women do appreciate it. And then, I don't know if I have it on there, but warm We also will put a warm washcloth or
Tell me
oh,
about it.
okay, hot packs in the perineum help to
Ease the
thank you, discomfort, and allow the perineum to stretch. So we'll get a warm washcloth or even hot. We make sure it's not too hot for you, and we'll put it on the perineum, and that helps those tissues to stretch more easily as well. So we'll use that and the oil together. Mother needs extra reassurance at this time most of the time. So it gets so intense, especially as baby moves into, let me just show you here, especially as baby moves right in here. This is so intense. This area is so tight and it is so full, and a lot of times mothers will want to just squeeze their hips and they'll squeeze their bum and they'll just grab the floor and they'll just be like, I can't do this. This is so much. And that's when she needs extra encouragement. Like, okay, this is your baby's head. Your baby's head is coming through. It's filling up the space. This is good. This is what you want. Your baby's almost here. She just needs that extra encouragement. And just tell her, you want to drop your bottom, relax into the bed or wherever you're at. Just relax your bottom. And if she can do that, if she can just relax her bottom and just let baby move through that intensity, that intense period will move more quickly. Move past it more quickly. Okay, active birthing positions. So positions you can actually be in for birthing. There's many of them. So you can see that there's so many options. This is most common in the hospital just because it's easier for the provider to access in case there's a special circumstance. A lot of women do end up in this position, but it doesn't have to be that position for birthing. And then I like this picture because it shows this is something that if a mother is in a semi-reclined position, which a lot of women do end up in, that if she can grab underneath her own legs and not have somebody else support her legs for her, if she will grab, and I know a lot of women, they're like, I can't do it, I'm so tired, which they are. They're so tired, almost every single woman has the strength to do it, even if they've been laboring for 2 days. They have the strength. Most all women still have that extra strength to do it, and it helps to shorten the birth path. If they can grab onto their knees and pull them up and out, it helps to shorten the birth path, and it helps to direct that slanted J breathing even better, and gives her leverage as well to use those pushes more effectively. Okay, cardinal movements of baby, the normal for normal labor. Just really quickly, so this is floating, this is engagement, this is descent, this is rotation and beginning descent extension, this is complete extension, restitution, delivery of the anterior shoulder right here, and then delivery of the posterior shoulder. And these again are all movements that the baby makes on its own. It's just so incredible without assistance from anyone in normal cases. They're just so smart and they know what to do. It's so incredible. Third and final stage, welcoming baby and bonding, placenta delivery. So welcoming the baby and bonding, this stage involves the birth of your baby. Baby reaches the perineum, crowns, and is born. Bonding can begin immediately when baby is placed on mother's abdomen. Some mothers need a minute, and that's okay. Don't feel bad if you're like, I just need a minute. Please don't put my baby on my chest right now. I just need a minute. That's okay. It's rare that happens, but we don't fault a mother for feeling that way, or if she just needs to gather, process, even if it's just 30 seconds, what happened, then we need to allow that. So she shouldn't be made to feel like she has to have her baby on her chest immediately. Most women do, and even if they say I need a minute, sometimes it is just like 30 seconds. They're like, okay, give me my baby. So, but for the most part, most women are just immediately, they just want. It's just that instinctive, almost automatic reaction for baby mothers to just go and reach for their babies and put them up on their chest. Or if the length of the cord allows, sometimes the cord is really short and you can only put baby like this far. So I just had somebody ask me the other day, one of their prenatals, they said, because we were talking about that, and he said, because his wife is close to delivering. And he said, well, and I said, that's what we'll do. And I said, unless the cord's really short. He's like, oh, I thought every single cord was the same size. I'm like, they're not. Some are very, very, very long, and some are like really short. So, Dad can participate by putting his hand on baby's back and talking to him. Skin to skin eye contact with all three is so important, with the mother, father, and baby. Skin to skin eye contact and talking to baby are crucial in bonding, as well as helping baby. It also helps baby to adjust to the newness of the environment. The first time when looking into your baby's eyes is one of the most spiritual and exciting moments ever. Most everything is forgotten at this point. Once you look into your baby's face and you smell your baby and you just have that warm feeling of that baby on your body, and it's just incredible. Most of all the difficult time that you had through labor is most of the time women just, it's all gone in that moment. Then later you remember about it and you're like, oh yeah, that was a lot of work. We even have some women say, oh, I could do that again, and you're like, what? Even if they've had a really super long, drawn out, hard, difficult birth, sometimes after they have their baby on their chest, they're like, I could do that again. And you're like, you are amazing. So, not always, but some women do that. Some women say that. Most cases, baby should be left right on mother's abdomen. Most everything can be done unless baby is super compromised, or mother is super compromised. Most everything can be done. You can check vitals, heart rate, breathing, color, chest, everything right on mother's chest. Mother's body adjusts her temperature to meet the baby's needs. Fluids from birth, vernix, and hormones secreted from baby's skin will stimulate mother's own hormones for regulating, healing, and breastfeeding. And also, a vaginal birth, as baby's moving through the vagina, it actually massages baby's chest to help expel the fluid, so that when baby comes and it takes that first breath, then the fluid can move out of those lungs even more quickly. Again, just showing it, I just like to show as many pictures as possible. The more you can visualize it, the more it helps during birthing. Onset of labor, this is what your cervix is looking like, and baby's moving down, flexion. Internal rotation of head, which baby does. Extension, there's that slanted J again, moving baby out. External rotation of head, and then after baby is born, you need to deliver the placenta. Some women don't realize that they need to deliver the placenta after the baby's born, so you do. You need to have it. There's no bones, so it'll just kind of feel like a look. Like, the best way to describe it. It's like you work so hard, and then you have your baby, and you've got your baby on your chest, and you're like, what? Why am I contracting again? Sometimes you forget, and you're, why am I contracting again? And then we're like, that's just a placenta. Placenta needs to come, and then all of a sudden, there's that fear. Oh, I'm gonna have to push so hard again, but it's really not even that hard of a push. Sometimes just coughing. We'll just tell, huh?
I didn't even notice it.
Yeah, a lot of women don't notice it. Most women do, and some of it is more effort than others, but sometimes just like we'll like kind of get it out, and it just kind of just slips through. It's just like this blob that just falls out or just moves out. Some of them are more work than others. So your placenta has amniotic sac on it. So baby's moved out and through the pelvis, and baby's born. Baby's up on here, and your placenta is still in. And this is the baby side. This is what we call the maternal side. This is what is attached to your uterus, this side of it. And the sac will flip over most cases. And this is what we call, one this way, sorry, I'm going backwards. This is what we call shiny Schultz or dirty Duncan. That's just something you might hear at birthing. But it should stay like this after baby comes and then move out. So it's attached, and so it'll pull off the uterine wall, and it'll fall down and out. And oftentimes, so there's two layers of the amniotic sac. So there's one here and one there that's protecting baby and holding baby and keeping baby in. And oftentimes when the placenta is delivered, there's one layer or another that might get hung up inside the uterus or inside the vagina, and we want to make sure that all of it comes out. So sometimes we have to work a little bit harder, and we have to push on the mother's tummy, sometimes really hard on the mother's tummy, and it is very uncomfortable. And it's not because we want to be mean, it's because we don't want to leave anything, any part of the placenta or the amniotic sac, we call membranes, left inside mother at all. Can cause severe infection and in some cases hospitalization. It's really dangerous to have this left behind. So we always make sure. So if you are at your birth and you notice us, most of the time we'll explain. We'll say, we've got to do this. We've got to push on your tummy, and we'll explain it to you. But if we do that, it's because we really don't want to leave that behind. And pushing on the mother's, the top of the fundal height, we're pushing on we call it curdaying. We'll say we're going to curday. We hold on to down here, and then we push on the top of the uterus, and we just push and we dig, and it just because it helps to massage that uterus and get that membrane piece out, because we don't want to leave it in. Okay, delivery of the placenta is the third stage continued. This is the organ that nourished your baby in the uterus. I just have several pictures just because it's really good to visualize. It also helps if sometimes we have a placenta that is just being stubborn and it doesn't want to come. So sometimes if you visualize what it needs to do and tell your placenta thank you, it might sound weird, but tell your placenta thank you and say let go, you need to come, then sometimes visualizing it and seeing what it needs to do will help it to come. Let me see what time it is. Okay, we're running out of time, so I'm going to skip over this. I'm just going to tell you, placenta's amazing. If you want to see it, if you guys want to take a picture of this, then please do. If you want to see your placenta, I highly recommend it. At least see what was carrying your baby, see where the cord insertion was. You know, it's really fascinating. It's incredible. Let's see. Talked already about a lot of that. Again, this is where it's attached. It pulls apart, and then it moves out. So this shows it already cut, the cord already cut, but we want to leave the cord on. So clamping and cutting of the umbilical cord can be delayed until it stops pulsing. I talked about that a little bit in, I think, the last classes. Anybody else need me to go over what it means, like the cord stop pulsing? Does everybody understand that pretty well? Okay. This allows a necessary blood transfusion personalized to your baby's needs. And contrary to some beliefs of some caregivers, it can be cut after the birth of the placenta, because sometimes in the hospital, the OB will say, well, we can't deliver the placenta until we cut it, which is completely absurd. It happens all the time that we deliver, the placenta is delivered without it being cut. Again, this is what the placenta looks like, a real picture of it. Maternal side and fetal side. So, really incredible. Delayed cord clamping, this is what a cord looks like before it's done sending all the blood to baby. This is what it's going to look like after. It's going to be more flat and thin. Okay. The golden hour and breastfeeding. The first hour after birth, when a mother has uninterrupted skin-to-skin contact with her newborn, is referred to as the golden hour. This period of time is critical for a newborn baby who has spent the last 9 months in a controlled environment, as well as the mother who went through many hormonal changes and biomechanical changes throughout pregnancy, labor, and birthing. So the benefits of the golden hour are obvious to us, but to some they're not so obvious. But these are just some of them. Regulates baby's temperature. It's more stable. The breathing is more stable and heart rate is more stable. And it actually stabilizes blood sugars. Allows baby and mother to recover from birth together. Enhances bonding time between mother and baby. Reduces postpartum bleeding for mother. Less chance of a postpartum hemorrhage. Not always the case, but some studies have shown that. increases breast milk supply, better breastfeeding success rates for mother and baby, and that's if with this golden hour you've used it to breastfeed. That's where this applies even more so. Decreases the risk of postpartum depression, anxiety, and mood disorders. Improved weight gain for baby. Studies have shown that newborns who participate in the golden hour have healthier sleep patterns and cry less. Even more critical for mother and baby if there was a birth trauma or a C-section. Okay, so really quick, I'm going to, does anybody need to just like get up and walk around for just a second before I go into that class for the breastfeeding? If you guys need to, then do. Okay, so I will race through this. I apologize, but very little time. And we did start 10 minutes late. Okay. Breast milk is specially formulated for optimal human growth, proteins that favor brain development because the baby's brain is growing so rapidly in that first year, and their body. So there are fats in the breast milk that you cannot find anywhere else. Some people try to duplicate it with formula or goat's milk or adding coconut oil and things like that to it, which are helpful if you can't have the breast milk, but breast milk is the very best for baby's brain and baby's body, and especially how rapidly they both grow. Cow's milk is what they use in formula, and they're proteins that favor muscle growth more than brain development. So breast milk supports and grows a healthy microbiome. Research is showing that nearly all diseases can be traced back to the health of the microbiome. Newborn's microbiome is started from passing through the birth canal and from colostrum received the first few days of life, and even to add to that, the first hour of life. Benefits for the baby for breast milk is it provides protection, less illness, hospitalization, immunities against human disease, lower rates of allergies, colic, constipation, asthma, chronic bowel diseases, obesity, diabetes, and cancer, promotes bonding, physical closeness, and hormones released during breastfeeding. For mom, it's a lot more cost. It's a lot better cost-wise. It's more convenient. You don't have to get up and make a bottle in the middle of the night. Lowers the risk of type 2 diabetes, rheumatoid arthritis, and lower rates of ovarian and breast cancer. So these are some of the things that are noticed even more so with women who can and do breastfeed. Lower rates of ovarian and breast cancer. Heart disease, osteoporosis, that's another one. Studies have shown that women who breastfeed have much less chance of getting osteoporosis and postpartum depression. Breast anatomy. So this is just showing, these are the ducts that the hormones that send the message to create the milk and store the milk. When these are massaged, they send the message to your pituitary and to your brain to create more breast milk. The alveoli are the little glands that store the breast milk, and the lobules are the clusters of the alveoli. So the areola is that dark spot right behind your nipple, and then here's the nipple. So the breast, this is just a very simple image of it. This is like looking right on the breast tissue back here, the areola, and these are the Montgomery tubercles. I think if I'm saying it right, tubercles. And we'll talk about those in a second. And the nipple. So these are important to remember because you want to make sure that baby is latching on and getting most of this area right here, the areola, not just the nipple, because it's called breastfed for a reason. Some babies, depending on the breast size, can even get past the areola and onto the breast, actual breast tissue, the skin of the breast. The Montgomery glands, or the tubercles, are bumps on your areola that help to lubricate the nipples. And you will, most women start noticing like secretion from those little bumps, like around 20 plus weeks. And that's perfectly normal, and it's just to lubricate the nipples and to get them prepared for breastfeeding. So when aiming for a good latch, baby's mouth should cover all or most of the areola, so right here. So here's the breast tissue behind it, or the skin, breast skin, and then here's the areola. This is where you want to have all or most of that in baby's mouth. Again, it depends on baby's mother's nipple size and breast size. Just get another picture of the areola and the nipple. The Montgomery glands, you can see them right here, little bumps. Perfectly normal. Some people used to think that there was something wrong if they had those. So breast changes during pregnancy. Breasts become fuller, larger, and more tender. That's development of the milk making structures within them. The skin around the breast may become thinner and veins more visible. That's because of the increased blood flow to the breasts, which helps with the milk supply. The nipple and areola may become wider, darker, and more sensitive. Babies have limited eyesight. Oh, that's missing an S on there. Babies have limited eyesight at birth, and it helps to guide them to the target, which is the nipple or the areola. Most mothers are fully capable of producing milk by 5 to 6 months gestation. So, mothers that have given birth to preemies, like around 22 weeks or so on, they can actually produce milk and pump and store it until baby is out of the NICU and able to go home. Some breasts leak colostrum, some do not. Either response is normal. Montgomery's tubercles glands, those glands are little bumps in and around the areola. They become more pronounced as you get closer to delivery. For most people, the little fluid that they secrete is an antibacterial lubricant. So it's actually better to not wash your breasts, your nipples, and your areola with soap. To just wash them with warm water and a gentle washcloth, because you want to keep those tubercles, that fluid secreted, you want to keep that on your breast tissue, on your nipples and on the areola. Stretch marks are possible with the breasts. A lot of women notice stretch marks. So it's really important to know your nipple type. If you don't know it already, I recommend you go look and find out what your nipple type is, and because there's things that you can do before baby is born to help either correct or adjust your nipple type so that baby can latch on better. Because some nipple types make it very, very difficult for baby to latch on, or they can't latch on at all. So this is common right here. This is flat, inverted, where the nipple actually sinks in, and then puffy. So this one is actually difficult for babies. So you can see that most of the areola, there's just a little nipple part right here, and the areola is really swollen. So this one and this one are most difficult for baby. This one can be managed for baby. This is definitely optimal, but with some work, but these ones are going to be the most difficult. So it's really good to know what you have before you have baby. There's all shapes and sizes of breasts. Breast and nipples come in, excuse me. Some may cause extra challenges when it comes to proper latching, just like I was talking about with the other slide. When you suspect a problem, seek help before delivery. Find out if you can help correct it before delivery, because you don't want to end up, giving birth to your baby and then struggling. You're already going to be so tired. You're going to be sore. Baby's going to be tired, and it's going to be a struggle already. It's already a challenge, even if you do have optimal nipple type. But if you don't, then it's going to be even more so of a challenge. So do the things that we can do, some things to help if they're not optimal. When to suspect a problem, if there's no change in breast size or tenderness. If that happens, it may indicate a problem with milk production. So you want to talk about that again before delivery. There's some supplements that can help with those. They're called galactagogues, and early intervention and hand expressing and pumping. I won't go into that a lot, but I'm going to send you guys some videos of hand expressing and pumping, and I highly recommend that at 37 weeks you start hand expressing, and you'll talk about that in the videos that I send you. So with flat or inverted nipples, it may cause extra challenges with latching, which can lead to problems with production as well. So it's so important that that first 1 to 2 hours after baby is born, that those milk glands are stimulated and that those hormones are sending the signals to your body to produce more colostrum and to start that milk production going, because baby's just getting colostrum, but the more that those milk glands are stimulated right after delivery, the better chances you have of long-term breastfeeding. So you want to assess to see if you have true flat or inverted nipples. I'm going to show you guys really quick the pinch test. So here's our little, if you take your breast and you just hold behind it, behind that areola, and you pinch, and when you pinch, if the nipple goes in, that's a true inverted nipple. Okay, if you pinch it, let me show you with this one. If you pinch it and it sticks out more, see this one kind of goes flat, but it doesn't go in. If it sticks out more, then you know it's not a true inverted nipple. So inverted is the worst. Flat is difficult, but inverted and that puffy one that I showed are the very worst. Let's see. Breast shells or shields help to draw out nipples, and I'll show you what those are in just a minute. Nipple shield may be needed in early days. A nipple shield is something that you actually put on. Let's see, I'll show a flat one. So this is a flat one. A nipple shield is something that you actually put over the nipple, and baby latches onto that shield, and as they suck, it helps to draw the nipple out into the shield and helps to express the milk for baby. It's something that you only want to use as a last resort, and if it helps, that's great. That's better than nothing, but you want to always try to nurse baby first and then put the shield on, so baby doesn't get so familiar with the shield that they only want that, and it kind of gets a nipple confusion. So pumping and hand expressing, again, are super helpful in this case, and possible supplementing are necessary when using a shield. We are the mind frame. I'm sure you guys have all heard that breast is best. I'm the mind frame of the mind frame that fed is best. So if you're having a difficult time and it's just a huge struggle and baby's not eating and you're not resting and there's a lot of anxiety surrounding this, then I think it's more important to feed the baby and give the mother some rest. If you've exhausted all of your resources and it's getting like several hours after birth and baby still hasn't latched and they're just so unhappy, then I feel like it's better to supplement baby at that point, so baby's blood sugars don't keep dropping and mother doesn't keep panicking. So, but if everything's going well, then of course you want to have the breast milk. Ask for guidance and directions for using breast shells if you're going to need them, or breast shields as well, or nipple shields. Reach out to a breastfeeding specialist before birth. Okay, so this is a breast shell. It's something that you wear in between nursing, and it just kind of presses against your breast tissue, and it helps the nipples to come out. This is a breast shield that you're going to put on your nipple or on your areola, and it's going to help draw the nipple out when baby nurses. And this is a breast shell that is a silverette cup, and it helps to prevent infections. These are like a new thing in the last few years that we've seen anyway, and they're super awesome. Like, I recommend everybody get some of these. They help prevent infection, and if you do have sore or cracked nipples, then they help those to heal more quickly. So you want to make sure that it's actual silver that you're getting, and if you do get them, then you want to, there's a film on the inside of them, you want to wash that off and scrub it off so it's the silver coming through. Okay, the first hour, the sacred hour, the golden hour, skin-to-skin contact immediately is always recommended, unless medically indicated, until after a full first feeding takes place. So the full first feeding is baby nurses fully on one side until baby pulls off on its own, like usually lasts around 20 to 30 minutes, and then you have like a little rest and digest period, and then baby nurses fully on the other side around 20 or 30 minutes. So it's even more so past an hour, that golden hour. 1 to 2 hours after birth, baby will be most alert and eager to suck. Colostrum most abundant for a good first feed at that 1 to 2 hours. And if you go past that 1 to 2 hours, studies have shown that babies have a more difficult time, and long-term breastfeeding can be impacted negatively. But some circumstances don't allow for it, so we do what we can when we can, but we want to encourage it as much as possible. Let's see. There's 4 times more colostrum in the first hour after baby is born. And when that's stimulated and baby has extracted that and nursed and pulled that out, then it has a multiplied impact on later milk production, like even months down the road. So the more often you nursed in that first week, even that, especially those first 24 hours, the more it sets you up for a positive supply, like for months on. Colostrum is liquid gold. It's in small quantities. It's perfect for newborn stomach capacity. It has white blood cells, high level of antibodies, reduces invasion of harmful bacteria, seals the inside of baby's intestines, provides much of the microbiome for life, not just for a little while, for life. Stimulates bowel movements, reducing risk of jaundice, and it's ideal for the first few days. It's super high in protein and low in sugar and fat, making it easy to digest, and exactly what baby needs too. So these are some breastfeeding positions, and I recommend, it might seem silly, I'm going to send you all these slides so you guys can review them if you want. I'll just email them to you. I ask that you guys don't share these with anybody, because a lot of work, in fact, all of the material that you guys have, if you guys will not copy and share, I don't mind you guys telling information or anything like that, but there's just so much work that goes into all of these. If you don't share copies, that will be very nice. Just be considerate of that. Positions for breastfeeding, these are optimal for right after birth. This is the very best one if you can get it to work. Some mothers can't, so we recommend what we call the football hold or the cross cradle hold. If you can find a baby doll somewhere and just practice these before your baby's born, it will help. These are not recommended until at least 2 weeks or around 2 weeks after baby is born, because it can actually, the way baby latches on when you're doing lying on your side or laying back is not going to stimulate that breast milk production, the hormones, to send that signal to produce more milk, like these positions will, and especially this one.
Shauna?
Yeah.
I've heard of women like gathering their colostrum like before the baby's even born,
Yeah.
and freezing it.
Yeah.
Do you think like that's like
Yes,
good
in
thing?
fact, that's what, so back here really quick, hand expression, and I was going to say I'm going to send you a video on it. So that is part of what I was talking about, and that, in fact, a lot of the ladies that I take care of, I recommend hand expressing before your baby is born and gathering the colostrum. So I'm glad you said that. I was going to say it anyway, but I'm going to say it now. Gathering that colostrum before your baby's born, you store it in little syringes, and you save it in the freezer, and then we'll talk about it in just a second. But it's so helpful for so many women. So this is how you want baby to latch. Again, help getting little doll and just like kind of practicing it. You can do it over your shirt or whatever you want, whatever you feel comfortable with, but practicing it will actually help. It seems silly, but it actually does help a lot of women to practice it with a doll before your baby's born. You want to make sure that the chin is resting as an anchor on the breast, and then you want baby to go on and grab onto the nipple. So nipple pointed towards either the lips or the nose. And let me see if I can. I don't know if it says it in the slides, but when you're first, you've got your baby and you're first trying to latch baby on, if you can sit up, and if you're a midwife or husband or everybody who's there to support you can help you sit up. It's better if you can sit upright and let your breast fall into baby's mouth, and rather than baby having to reach forward or reach up for your breast tissue. And you want to line baby up, baby's chest against your chest, and baby's mouth to your nipple, and that's the best alignment for baby and mother. Causes of nipple pain or trauma: incorrect latch positioning, flat inverted nipples, a lip or tongue tie, and I'll talk a little bit more about that in just a second. Improper flange fit. A flange fit is when you have a breast pump and there's the inside where your nipple goes through to pump the milk. If it doesn't fit correctly, it can actually damage the nipple tissue. Infection, and infection is usually secondary to these other issues. So this is what a healthy nipple should look like when a baby pulls off after breastfeeding. These are nipples that could indicate you're going to have some trauma if your nipples are looking like this after baby pulls off. So this is, I don't know if you can see it very well, but it's like flat. Baby tongue or lip tied. These are some symptoms that might indicate that your baby is tongue or lip tied. At home births, we always check to see if baby's tongue or lip tied. Sometimes we can't tell, and if we can't tell, we'll refer you to a caregiver who can help correct it or assess it for you. In the hospital, they are really, really not very nice about us telling mothers that their baby has a lip or tongue tie for some reason or another. They don't like us to tell that. They'll actually get upset if we say it. But it can cause major issues if a baby does have a lip or tongue tie, so we highly recommend them get it corrected if you do. They're very, very common. It's on the rise for some reason. A lot more babies than we ever used to see have lip or tongue ties. So symptoms are painful nursing, poor latch, cracked, creased, flattened nipples, bleeding nipples, lipstick-shaped nipples like we showed in the picture before, poor breast drainage, like they're just not, baby's not expressing all the milk, low supply, plugged ducts, engorgement, mastitis, nipple thrush. Nipple thrush is like a yeast infection that's reoccurring. Need for a nipple shield, like I mentioned before, feeling like baby wants to nurse constantly and not seeming satisfied. Symptoms with baby are poor latch. They're just struggle to latch over and over and over again, and even with a bottle, they struggle with a bottle. They fall asleep while feeding. There's a misconception that babies are lazy when they're born. Babies are not lazy, they're tired, but when they want to eat, they want to eat, and they're going to latch on, and they should nurse vigorously. But if they keep falling asleep when they first latch on and they just start to fall asleep right after they first latch on and they've gone a couple hours, usually that indicates a lip or tongue tie or nipple issue. Fussy, reflux, spits up, and gassy. Clicking, smacking sounds when they're trying to nurse. Poor weight gain. Biting, chewing nipple, pacifier falls out easily. This is on here, but I recommend not letting babies have pacifiers at all until like 2 weeks, just because they can get that nipple confusion. And sometimes mothers will give babies pacifiers and they won't see their hunger cues and won't feed them in time. Milk dribbles or comes out of nose. Milk dribbles down the side of the mouth. There's the normal milk dribbling from a baby getting a bunch of milk, like milk overflow, but there's a milk dribbling where it's just draining out instead of them swallowing it down their throat. Mouth breathing, snoring, noisy breathing, more than 30-minute feeds after newborn stage, frustration at breast with bottle. Sore nipple treatment, correct your latch, assess your flange fit if you're pumping. Nipple ointment, not lanolin. Lanolin's been shown to cause more issues than actually help. She has on here Newman's prescription, but I honestly don't know what that is. Mother Love breastfeeding nipple cream is really a clean product, and there's others that are similar to its ingredients. Or sometimes just olive oil and coconut oil and grass-fed beef tallow are super helpful for lubricating the nipples. Saline soaks, mix 1 teaspoon of salt and 2 cups of boiled water, let it cool to warm, dip gauze in the solution and place on nipples for 5 to 10 minutes, and then blot it dry and apply the ointment, salve, or olive oil. Gel pads are something that you can buy at the store, and they just are, you can have heat, hot or cool, and put them on there for comfort on your breasts. Breast gels, like I showed you before, Silverette nursing cups, rubbing a few drops of breast milk or colostrum on your nipples and then just letting it air dry has also been helpful. Artificial nipples, so I'm just going to say really quick, again, I encourage you waiting until 2 weeks so the baby doesn't get nipple confusion before you introduce a pacifier. And these ones right here are the better choice, and these ones are not ideal. So I will send you these slides. So if you're getting them as gifts at your baby showers, or if you're going to buy them, avoid these ones that are shaped like this and try to go for these ones. Okay, so milk that you're producing for your baby is a supply and demand issue. So just like when there's things left on the shelves and they just don't get bought, and the store pull them off and get rid of them. So it's kind of the same idea with your breast milk supply. If baby's buying it, it's draining it, it's using up that breast milk, then it's going to send a signal to your body to produce more and more and more. But if the milk just sits in the breast, then it's going to be a signal to your body that your baby doesn't need it, so it will stop producing as much. So you want to make sure you're feeding your baby frequently, and even not only feeding the baby frequently, but long sessions of nursing, allowing them to nurse for as long as they will, and don't set babies on a schedule. Let them set the pace. So production. This is Dr. Jane Morton. The lady in the video that I'm going to send you about hand expression. And this is just a quote that she has, but I'm going to skip over it. But I'm just going to say down here, if a mother expresses milk in the first hour versus the 2 to 6 hours after birth, she expresses 4 times more the amount of colostrum, and at 3 weeks she's producing 130% more milk. This is on average, 130% more milk than the mother who began at hours 2 to 6. And then afterwards, who only expressed an average of 5 feeds in 24 hours and 3 days. 24 hours for consecutively, for 3 days. So it's just pretty much saying that it's so important in those first few days to nurse often, and to let baby nurse a long time if they will, as long as they will. So what is hand expression? I'm going to skip over this just because I'm going to send you the videos and there's lack of time, and it really explains it really well. I highly recommend, if you have time and if you can, to start expressing the colostrum at 37 weeks. Is my baby getting enough? Babies should be fed 8 to 12 times in 24 hours, especially in those first few days. Established supply should be 1 to 1.5 ounces per hour in that first few days. Possible signs your baby could be undernourished, jaundice, frequent feeding, comes off breast unsatisfied. A way to tell if your baby is satisfied after feeding is if their hands fall open and they're just relaxed. If a baby is clenching their fists, then they most likely didn't get very much, and they're still hungry if they're clenching their fists and they're holding them like this. But if they come away from the breast and their hands just drop and are floppy and they just kind of just hang back, but they still have all their reflexes working well, then that's a good indication that baby's fed well. Infrequent feeding, falls asleep at the breast. Again, babies are not lazy. They want to nurse. So they shouldn't fall asleep at the breast if they've gone a couple hours without feeding, 2 to 3 hours. Ideal diaper output, day 1, you want to have at least 1 wet diaper and 1 stool diaper. Day 2, 2 wets, 2 stools. Day 3, 3 wets, 3 stools. Day 4, 4 to 6 wets, 4 stools. If the output is less, then check baby's weight, and you can also ask for the blood sugar status, see how baby's blood sugars are. But generally, you want to know these things before it gets to day 4. Within the first couple days, you want to have a good idea of what baby's doing with latching and feeding. Low supply risk factors. These are some risk factors that could cause you to have low milk supply. PCOS is a really big one, and diabetes and infertility, somebody who struggled with infertility for many years. Widely spaced breasts that don't grow in pregnancy might indicate that you might have a supply issue. Sometimes preemies can cause a supply issue, not always. Retained placental tissue, or those membranes that I was talking about, sometimes that can cause your body to not produce milk. If you've had an epidural, preeclampsia, excessive swelling, postpartum hemorrhage, sometimes that can affect your breast milk supply. If you're ever curious, if you need help at all, always ask for help. These are some ways to increase production, stimulation, especially in the early days. Again, I can't emphasize enough how important it is to get those breasts stimulated frequently in those first few days to help for long-term breastfeeding success. Health and recovery, so make sure you get rest. Your diet, increase your proteins, fats, and healthy carbohydrates. Hydration, make sure you're drinking a ton. Breast milk is a lot of it is water. Galactagogues, those are herbs and tinctures and supplements that help with supply. Sometimes those are needed. And some, you want to be careful with those, though. If you're wondering about them at all, ask your midwife, because there's some that can actually negatively affect you. So pumping can help too. This is the flange fit that I was talking about. This shows a flange that's too large. You can see there's too much space around the nipple. One that's too small, the nipple is just too really tight in there. And then a good fit flange has a little bit of space all the way around. I'm not going to go into all of it, but pumping can help improve your breast milk supply if you're wondering if you don't have enough, and there's ways to do it, and we can give more help if you need it. This is, again, size guide. So these are helpful if you want to pump. If you're feeling like you're going to pump, just make sure that you're looking at this and knowing that you're getting the correct flange fit. Some people don't want to, and that's fine. Again, this is how to measure your flange fit. And it shouldn't be painful when you pump, and you want to use a pump that has a stimulation mode or a low suction mode, and then increase to high. And you want to pump at the highest comfortable suction. You can pump to boost your supply when you're separated from your baby, every 3 hours or more often. And when baby cannot provide adequate stimulation or emptying of the breast because of a lip or tongue tie or the nipple size or shape, they're generally covered by insurance. So if you have insurance and you want to pump, I recommend, or if you're even just considering a pump, I recommend getting one with your insurance before your baby's born. And do your research before choosing a pump. It's not on here, but my favorite pumps, if you guys want to write them down, are the Spectra and the Medela brand. So those are some of the best pumps that I've found out there. Your breasts, after about 24 hours, 36 hours, your breast milk will change from colostrum to milk. And when that happens, your breast will become full and hard, and that's what we call engorgement. And it is a real thing. Like, it can be very, very painful. So you want to be aware of the signs of engorgement and get, and so I'll talk about how to help it. Engorgement treatment: a warm compress and gentle massage with extra virgin olive oil, warm shower with gentle massage and hand expression. You want, gentle is key. Like, some people think that they need to be forceful to remove that milk because it's so hard, but you want to be gentle with them because you don't want to damage the breast tissue or those milk glands or the nipple tissue or even the areola. So you can pump to relieve some of the pressure, avoid excessive heat and pressure, and excessive pumping. These can increase swelling and inflammation and damage to the sensitive milk glands. Cold cabbage leaves are also helpful if your engorgement is just so bad and you just can't find relief. But I would,
I was dry up your
I was going to say, I do it with caution, because if you use the cold cabbage leaves too much, it can actually dry up your milk. So just enough to just soften the breast tissue and not leave it on for very long, for like 20 minutes or so. Aim to feed every 2 hours. So this is also a massage that helps with just milk production in general, and also if you're feeling engorgement. and it's just gentle, like petting a cat. So you don't need to use a lot of pressure, but it just shows the movements that you would use to massage that those glands up here. There's glands all the way, even underneath your armpit, there's milk glands. So you can massage them in these motions here. This is very, very helpful just in general too, just so you guys know, for many reasons, milk production and to prevent soreness. If you have a clogged milk duct, these are some, clogged milk duct is actually pretty painful. And so it's one of the ducts that's actually inside the breast tissue, and it can be very, very painful. So these are some ideas to help prevent it or to help them. Make sure your bra is not too tight. Make sure you're staying hydrated. Sometimes women who are not drinking enough, they'll continually get clogged milk ducts. Moist heat prior to nursing. Hand expressing in the shower. Nurse frequently, every 2 hours, starting with affected breast if you have a clogged milk duct. Using hands or vibrator to gently massage while nursing or pumping. So when you use your hands to massage the breast tissue, you're just going to take your hands in a fist and you're just going to go like this, just gently while you're nursing. You don't need to do a lot of pressure, and you can go up like this, and that helps to just release that milk duct, and you can go all the way around as far as you can reach. Or you can use the massager that it shows there, or this thing vibrates and massages, and if you get the right kind, they actually do heat as well, and you can find these on Amazon. They're really nice. Saline soaps also help. Sunflower lecithin, if you're prone, if you keep getting them over and over, you can look at these things, make sure you're doing them. Also, just taking sunflower lecithin has been known to help treat them and prevent them. Warm castor oil compresses, and watch for signs of infection. If you have a sign of infection, then please talk to your caregiver. A breast infection is very serious. I have known of women who have had mastitis in one breast, and they're generally in one breast or the other, not always. I mean, most common, just one breast. It's hardly ever that you find it in both. But I know of a couple women who have had mastitis and not taken care of it properly, and they were not able to nurse out of that breast very well at all, even with other babies after that. So very, very important that you get it taken care of when you notice it. I've known women that have been hospitalized because of mastitis. So not something you want to mess around with at all. Most common in the first 3 months and in winter months usually follows untreated damaged nipples or clogged ducts that we were talking about before. Poor feeds, infrequent feeds, anemia, stress, fatigue, poor fitted bra, flu-like symptoms is what you'll notice at first. And then and sometimes you'll be feeling perfectly fine, and then the next hour you'll be feeling like you were hit by a truck. Like it sets on that fast, mastitis can. Not always, but a lot of times it does. Hard, reddened, and painful breasts are what you would notice. And you can treat them with antibiotics, but there's also natural treatments. If the natural treatments aren't working within a day, I would recommend getting hold of a doctor and getting an antibiotic for it. Usually only one breast is affected. Rest, moist heat, ibuprofen is also helpful. Frequent nursing every 2 hours, but don't use the ibuprofen just to make yourself feel better and then not treat it. So you don't want it to mask it so much that you're not treating it. Frequent nursing every 2 hours, pump if needed. Pumping is actually very helpful for mastitis. Increase your fluids. Delayed treatment can lead to loss of milk production, ineffective breast, or even sepsis, like I said. This is a mastitis tea recipe. I'm not going to read over it. You'll have it in this slide. So that's all. That's all for that. I did race through it like crazy. There's so much more information I wanted to give you on breastfeeding, but I think I got the highlights of it. I really, really recommend that if you guys get that video, or when you get that video, that you try hand expression. Even if you don't store the milk now, try the hand expression before you have your babies at 37 weeks. So this will be in the slide, but if you guys want to line up a lactation consultant before you have your babies, I highly recommend it. Even if it's not her, if there's somebody else that you know, And then if you end up not needing it, then you can just call them and say, oh, I don't need you, everything's great, and they're happy. They're happy for you that everything's great. But I would recommend lining one up before you have your baby, especially for first-time moms. So I have a lot more on postpartum. I'll send you the slides because we're out of time. Just 1 second. Postpartum recovery and care for mother and for baby. And because we're out of time, I will just send that over to you. And I just recommend you guys, so right here, I go into a lot because it's so, so important to make sure that mother gets proper care. After baby arrives, after baby arrives. So I'll send you at least this. I don't know, because I'm not technically inclined. I might not know how to send you just part of it. So you might just get all of it. I don't know. But I would love to go over it with you. If you have any other questions about it, you can call me. But it's very important that mother is taken care of properly and that you have help lined up before baby comes. Like if family members offer help, don't turn them down. Even if you just think, oh, we've got it. It's just us two. We've got it. But dad's going to be busy taking care of mom, and sometimes mom and baby, and mom is going to need to rest, and even more so depending on how the birth goes, if she's had a traumatic birth or a very long and drawn out birth, if possibly hemorrhaged after, things like that. So it's so, so important that mom is allowed adequate rest and is fed really well. And so hopefully you can go over these, and I'll see if I can figure out how to send them to you. But this is what is really, really important stuff. There's quite a few slides, but yeah, hopefully I can figure it out. Any questions on any of it? Yeah.
Did you go over how what you eat affects your baby for breast milk?
I didn't go over that.
Yeah. I was just gonna say, like, if you're eating spicy foods, and just how some people can't do dairy when they're breastfeeding because it affects their babies. Also, eating garlic will increase your milk supply, I've heard.
Yeah.
And
Yep.
just different things will decrease or increase your milk supply and will affect your baby. So
Yeah.
I didn't know if you touched on that or not.
Yeah. Yes. So Laura was saying that different things will affect your milk supply, either like the foods that you eat, either negatively or positively. So I'm glad that you said that about garlic. So a lot of people can eat spicy foods and it not affect their babies, and some people can't. Really just depends on the person and the baby too, and their digestive system. Some people can't eat dairy, or it affects their babies negatively. But I am of the mindset that it could be the dairy that they're eating, the dairy that they're consuming, that is affecting their baby adversely. And then also garlic. There's actually been studies that have been done that babies prefer garlic-tainted milk over milk that's come from women who have eaten a lot of sugar. So garlic and onion and things like that, especially garlic more so than onion, but babies actually prefer garlic-tainted milk. So anyway, and it actually helps with their stomach too.
That is
Yeah.
interesting. I never knew that. I just know it sometimes increases your milk.
Yeah, it can. Yep. So anyway, any questions on any of it, please don't hesitate to call me or text me or ask me. I feel like, I know we rushed through it like crazy. So much information. I would love for you guys to be able to get this part. Hopefully I can figure it out. So anyway, we'll just end now.